Okay, let's everybody start finding a seat. Well, thank you, and glad to see everyone out this morning for our second day of the Rural Development Council here in Jasper. Really want to thank the folks that sponsored our dinner last night and everybody for being there, and it was a lot of fun. We sure do appreciate it. I just got a couple of comments. You know, the speakers today, just let me give you just a little hint. You know, some of you have 10 minutes, some have 20, some have 30, or you may have 4 people with an hour. If you got a bunch of slides, remember, though people may not believe it, we can read. And so don't sit up there and read your slides to us. I mean, talk about them. Make sure that you are taking time to tell us what you need, the issues, and what we can do about it. You know, everyone in this room that's around this table has been in the legislature for a while, knows generally. You know, I just met a lady, I didn't even know what she did, but we generally know the big pictures of what's going on. And so know that. You know, we don't need to know your mission statement generally and things like that, but we really need to know the issues. And I think, Sam, is that amen?
Amen.
Amen, okay. So going with that, because we really want you to make room for questions, and because that's very important, that these committee members have the opportunity to ask you a question. So starting off, we're going to have a little panel, and if the panel will go ahead and get up there. These are folks on school-based health centers, and we have 4 folks, and they have an hour. And I kind of gave them, I said, each of you go at it for about 10 minutes and tell us what we need to know, and then then it'll be up to the committee to just find out and ask questions. So the committee's been great. Some of y'all were here yesterday and know that they asked some pretty tough questions and are very prying and knowledgeable. And but I'll just let you introduce yourself. I don't know the order of the folks here. And so if you will, just go ahead and get started, and thank you. It's on. Yes, ma'am.
So good morning. We just drove up from Atlanta. It was a lovely drive up. It's a good thing we weren't going the opposite direction, or we'd still be in traffic. So my name is, I'm Dr. Vita Johnson. I'm a general pediatrician and professor of pediatrics at Emory University School of Medicine, and also direct a program called Partners for Equity in Child and Adolescent Health. And the whole purpose of Partners, which was developed about 10 years ago, was to increase access to health care and improve the delivery of health care for underserved children throughout the state of Georgia. We have 4 basic tenets to our program. One is to expand school-based health centers, because that's probably the most important aspect of our work. The second is to create a sort of family-centered approach to providing health care for at-risk families. Third has to do with early childhood literacy and school readiness. And the fourth deals with how we train our residents so they'll understand how to care for underserved children. So our work with school-based health centers, like I said, started about 10 years ago. We only had 2 school-based health centers in the state at the time.
I won't interrupt you. Tell us, what is a school-based health center?
Okay.
I mean, I think you might get everybody to a similar amount of knowledge.
Okay, so basically school-based health centers, I always describe as having a doctor's office in the school. And it is one of the, sort of every service that you would actually receive in your doctor's office, you should be able to receive in the school-based health center. It's just located where children are. And so as such, it eliminates every barrier to health care that you could think of. So if you think of transportation, especially when we're talking about rural communities, the cost, hours of operation, and a parent's inability to prioritize the health care needs of their children because they're working maybe 2 jobs, or maybe these children are being cared for by a grandparent or great-grandparent, you essentially eliminate every barrier to health care that you could think of. So that's what a school-based health center is. It's very comprehensive, holistic, and it becomes integrated into the very culture of the school. So it's sort of a seamless. You never know if the school-based health centers are part of the school system or vice versa. So we started this work about 10 years ago to expand, because we only had 2 in the state. Our goal was to expand it by 1 to 2 each year, and we realized that There are a couple of things that need to take place before you can take school-based health centers to scale. The first, you have to get community buy-in and support, because if the community doesn't support it, you might as well not do it. The second thing you need to do is come up with a model that you know will sustain itself financially. And the third thing is that you can demonstrate that what you're doing is a value, that these children's health is better, that they have greater attendance, and that they're doing better academically. And the fourth thing you have to demonstrate is that you have this, what we call implementation fidelity, that you're loyal to a model that you know that works. So we started this process by giving planning grants to counties throughout the state of Georgia, and you have a map of those planning grants with you. And our goal was to bring communities together over the course of a year so they could first define the needs of their children and then come up with strategies to address it through school-based health. They convene stakeholders. They do needs assessments. We bring them up to Emory 3 times throughout that year and do workshops, and then we travel throughout the state to actually do community forums. When I started this, I'm from Atlanta. I had no idea we had 159 counties. It's amazing. And so we've traveled probably all from the north to the south and east to the west over the past 6 or 7 years. We now have 48 school-based health centers. We started with 2, and over the past 6 years, they've grown to 48. And we realize, based on our analysis and data that we've collected, that we've increased seat time for these children. We've actually improved their health outcomes, especially for children with chronic problems like asthma and obesity, and done a lot around health maintenance, but also mental health. And of the 48 school-based health centers that have currently been developed, over half of them are in the rural parts of the state. We didn't start off thinking we would do rural Georgia. We thought we would be an urban area where we would focus on the Atlanta metropolitan area. But when we start issuing these planning grants, all of these counties all over the state start applying. And so we realized that this was a great opportunity to really address the rural aspects of the state. When we first started, we didn't understand the need. We definitely understand the need right now because we've actually gone into these communities and talked with all the stakeholders and realized that this is a priority for them. Some of the school-based health centers that we have service not only the children, but their parents and their grandparents, teachers and other folks in the community. We have wonderful models, and Stephen is going to talk about his model in Murray County. We have one in Dade County that actually is open to the entire community, and they're probably the most productive school-based health center in the state. So our goal really is to really focus on those counties that have no pediatricians, that have no providers, and to see if we can help them bring together all of the resources they have so they can expand their outreach of health to their community. So with that, I'll just turn it over to Stephen.
Actually, I think Dwayne is next.
Thank you. Good morning. My name is Dwayne Kafka. I'm the Executive Director of the Georgia Primary Care Association. We represent all the federally qualified health centers in Georgia. A federally qualified health center, or FQHC, or some people call them community health centers, is a federally funded program basically providing to help states or areas provide health care primarily to the poor and to the uninsured. About 70% on an average, looking at statewide of all of our organizations collectively, about 70% of our patients are either uninsured or on Medicaid. Again, that's our primary focus. Okay. The FQHC program actually is over 50 years old. Okay, it started a long time ago. We have one in Atlanta, South Side, which is right near the old Turner Field, that celebrated their 50th anniversary 2 years ago. So they're one of the oldest in the country. We've had good bipartisan support for the project over the years. When I got here about 20 years ago, it was right at the right time. President Bush, the younger President Bush, really focused on FQHCs. Part of his platform was to double the number while he was in office. I was always kind of curious as to why he had such a focus on what we did, and I was with some people from Texas once, and I asked them why, and they explained to me that Mrs. Bush had served on the board of directors of one in Texas and had taken him to some of the events and different activities that they had, and he was impressed, whatever. So it was good for us. We've experienced a lot of growth, and I'll come back to that in a second. We right now have 34 organizations, 34 501c3. One of the things for an FQHC is you must be a 501c3, a nonprofit organization, governed by a community board, board of directors from the local community or from the areas that comprise your service area. And one of the key principles of what we do, and the governance part, is that 51% of the board of directors must be users of the service. They must be patients, within your organization. So it's a good model, and again, the primary focus is on community-based services. Right now, as I said, we have 34 organizations. We grew from 17 during the time that I've been here. We've doubled the number of organizations. At that point, about 19 years ago, we had 75 clinic sites. Today, we have 225 clinic sites spread all over the state. You should have a map, I think, with your packet. This version kind of shows you. We're basically northwest, southeast, all over the state. And one of our focuses has been on growth. Okay, and we've done working with our member organizations, we've done a pretty good job. Our role as the Primary Care Association is to work with the member organizations. We provide support, technical support, training. We work with them kind of one-on-one. We work with them as a group. And again, the overall goal is to promote the growth and expansion of the system throughout the state. We've been focusing on, one of our focuses, has been on school-based. It's right now we have, Avita mentioned the total number. About 32 of those are FQHCs in the state. The newest school-based program we have, actually, she mentioned one up in Dade or whatever that serves the community. We just, about a year ago, we were working with Tolliver County down in Crawfordville, and working with the school district, working with our member in that particular area. Community Healthcare Systems serves that area. We were working with the school superintendent. His name's Alan Ford. Alan, as we were talking, whatever, Alan, basically said, look, if we put it in the school, then we're going to be limited. He looked out his window. He said, look at all that property out there. He said, if you put something out there, then you can see the whole community. And that's what we did. Working with Alan, with the school, he was able to acquire, I guess the school systems, whatever, have modular units that are available, whatever. He was able to help us and acquire a modular unit. And last October, we had the dedication. So we have a new school base, but it is open to the entire community on the campus of the Tolliver County School District. In that particular case, as you all know, it's a small county. All the schools are located on the same campus, elementary, middle school, and high school. So it was a great addition to the community. We're also focusing on behavioral health. One of the big focuses, as you all know, we read about it every day in the newspaper, the opioid epidemic. And our funding source, the Health Resources Service Administration, as part of HHS, the federal government, is promoting our growth or our expansion into integrated behavioral health services. So over the last 2 years, whatever, they have provided additional funding for our organizations to do that. We are working with other community-based behavioral health groups, the community service boards as an example, trying to do some type of integration to avoid duplication of services, but yet to provide as much comprehensive care as we can. The future looks good, for us. The last time that we had a specific funding opportunity for school-based health clinics was in 2011. I didn't realize it was that long ago. But in the budget that's currently being discussed at the federal level, they do have additional funding this year for school-based systems. So we're kind of encouraged by that and hoping that that will come to fruition so that we can continue to expand in Georgia. So with that, I'm going to turn it over to Steve.
Thank you and good morning. I appreciate the opportunity to talk to you about what has become a passion for me and my organization, and that's school-based health centers. The story of the school-based health center really centers around a woman by the name of Heather. Heather has 2 small children, Jenna and Brittany, who are elementary school kids who go to school at Chatsworth Elementary School. My organization is an FQHC. As Dwayne indicated, we provide primary care services in 4 communities in North Georgia. Not only do we provide primary health care, but we have a dental program that is focused on providing care to children, and we have a behavioral health program that is coordinated by a psychologist who is full-time on our staff. So, and we have a staff of counselors that work with him. In 2012, we applied for a planning grant from Emory University, and we were fortunate to receive that. That planning grant, as Dr. Johnson said, gave us the opportunity to gauge the temperature in the community for support for a school-based health center. We had already established a freestanding community health center in Chatsworth, and so this was an extension of our practice. What we found is that in this community, there was a dramatic amount of interest. Chatsworth, Murray County at the time, had a half-time pediatrician to service a population of just under 40,000 people. There are about 10,000 students that are in the school system there. So there was a significant shortage of pediatricians in that community. Family practice docs, of course, could see children and did see children, but trained professionals in pediatrics were not readily accessible in that community. A little bit more about Murray County. 18% of the residents live in poverty. 36.5% of students 18 and under live in poverty. 42% of single-family households also live in poverty in Murray County. Heather and her children represent all three of those categories. Heather drives 27 minutes one way to get to a minimum wage job in another county. When her children need health care services, she has to leave work, drive 26 minutes to school, pick up the child, take the child to a doctor, and then go back to work or not go back to work. Sometimes the child returns to school, sometimes she doesn't. When our health center opened, it works like this. The teacher identified, this happened last year. Jenna, who was in second grade, had a stomach virus, and the teacher identified that student had something going on. The teacher brought the student down to our office, which was just down the hall from the classroom. At the beginning of the school year, we had asked all parents to sign a consent for treatment. Heather did that for us, and she did that for her child. So when the child presented, the first thing our staff did was to call Heather at her workplace, and Heather was able to take a couple of minutes out of work to give consent for treatment. With that consent, we were able to take care of the child. After we delivered care, we called Heather, the mom, and said, here's what we did, and here are the follow-up instructions. Heather was able to take that call a couple of minutes out of her workday, did that during her break. The child in this instance was able to get back to the classroom. Mom was able to take just a couple of minutes to provide health care for her child. So this low-income employee was able to save income for several hours, which was important for this hourly wage employee. So she was able to get good care for her child. This teacher in the school system was happy because the student was able to get back into class and was be able to get good quality health care, and mom was able to stay employed for several hours. So it was a win for everybody in the organization and everybody associated with our group. Our relationship with the school system is very similar to what Dr. Johnson said. We see the school system as a partner. And as a partner, we try to be very integrated with what goes on in school. So we participate as a medical component during field day. We provide educational programs to staff and teachers. And we actually provide educational programs to students in their classrooms, all provided by a qualified nurse practitioner who is a full-time employee of our organization. We staff the health center at Chatsworth Elementary School every day that the school is in session. So we are there for students, siblings of students, staff, and teachers. Not only do we provide services for those folks, but we also provide discounted services medical services for staff. Two examples would be flu shots for bus drivers and staff at the appropriate time. We also are available to do barometric screening for teachers who belong to the state health benefit plan and have insurance coverage there. And they can do that without leaving from work. They can just go walk down the hallway and avail themselves of our services. We have a contract with the school system. That contract has certain responsibilities and obligations. The school system provides a space for us and provides utilities, and that's their investment. We provide a full-time staff and all the supplies and medical services that are attendant to that. In terms of liability, our organization is covered by the Federal Tort Claims Act. That allows us to be a low-cost provider of care. We also have other liability, which is cross-indemnified between the school and us, so that if there is an adverse result as a result of our negligence, then we indemnify the school for that, and vice versa. Our services are inside the school system, so that's our model. We have been in the school system now since 2015, so we've got about 3 years or so under our belt, 3.5 years. And the school system is asking us to expand to other schools in the district. Currently, they have three full-time nurses on their staff to cover 11 schools. We take care of one of those, so the nurses on staff at the school system are now able to cover 10 instead of 11. We'd like to expand our services to other schools in the district, and so we're talking about telemedicine, which you'll hear about by our next speaker. The school-based health center is a success for Heather, for the school system, and for our organization. And we're providing good care for people, care that they might not otherwise would have had, care that keeps people in schools, and cares that keep mom at work. I'll be happy to entertain any questions once we're done with all the panelists.
Good morning. I'm Sherry Williams with the Georgia Partnership for Telehealth, and I'm going to tell you about something a little different than what these guys have already told you about. And this is how to use technology as a way to leverage services all throughout the state. A little bit about Georgia Partnership for Telehealth. We're a not-for-profit telehealth organization out of Waycross, Blackshear area. And we've been around since the early 2000s. School-based health just happens to be one of the areas we work in, but if you can put a medical clinic there, pretty much that's where we are in our state, and actually across 11 states and 4 countries outside of the U.S. We have quite a large footprint. I was asked to talk a little bit about telehealth versus telemedicine. And they're very interchangeable. There's one little tiny difference. Telehealth is like the big umbrella. It includes everything teleeducation, whatever. Telemedicine is the actual application of telemedicine. So if you're going to look at an ear, if you're going to look at a throat, that's telemedicine. When you look at our schools, we're in approximately 140 schools in Georgia, and that's 32 school districts. We're also in a couple of other states in a school-based health capacity. And the general setup of a school-based telehealth center, the school nurse is usually in charge of that clinic and usually in charge of that telemedicine component. And the state of Georgia requires that a telemedicine visit mimics almost exactly what would happen in a traditional face-to-face visit. So if a provider needed to look in an ear, you have to be able to do that same thing through technology. If they need to listen to heart and lung sounds, you have to be able to provide that capacity. So all of our 140 some odd school-based health centers has all that technology so that they can perform a complete patient examination with that physician. There are a couple of examples I want to point your attention to in terms of what's happened in the state, and one is in a rural community, and this is Unison Behavioral Health down in Waycross. They lost their psychiatrist a couple of years ago. She moved over to Donaldsonville, Dr. Kaylin Lane, and they really needed a way for her to be able to connect in and see their patients. She was having a lot of windshield time driving back and forth to see patients a couple of days a week. So they started using telemedicine inside their clinic. So she stays at her home office in Donaldsonville, and she's the virtual doctor for the Unison Behavioral Health Program. A lot of those patients at that behavioral health program are also students in the Ware County School and in the Pierce County School. and in the Atkinson County School, and in the Coffee County schools. So there's like, what a great way to be able to see these patients, because the patients sometimes are having a hard time getting in for their regular appointments. So she still sits at her home in Donaldsonville, and every single day, all day long, she sees patients in a virtual manner, either at Unison Behavioral Health or in one of those 4 school districts. So those children get comprehensive care from her as needed and as scheduled. Another example, and it happens to be another mental health example, is the Chris 180 program out of Atlanta. They use telehealth. They're probably one of the largest users of telehealth in terms of mental health in our state. They service a lot of schools and a lot of children. And there's just a few of them, and they can't be everywhere all the time, and they can't get the psychiatrist everywhere all the time. So they use telehealth as a way to be able to link all of those providers together to all of those schools and all of those students. It's just an excellent way to be able to leverage their limited number of people and leverage them throughout a very large area. What we do is kind of interesting in terms of funding. We don't require any additional funding from the state. We have never gotten funding from the state for our school-based health programs. In order to start a school-based health program with the equipment that we just discussed, it runs around $8,000. That's a lot for a school system, but in terms of health care, that's kind of a drop in the bucket. It's not a whole lot of money. And that's a one-time cost, and then annually you're looking at about $1,200. Well, when you look at Medicaid reimbursement here in the state, standard Medicaid reimburses $20.52 for an originating site. An originating site is a place where the patient is presenting from. In this case, the school. DCH several years ago added in the telehealth guidance the ability for school-based telehealth centers to be able to bill and receive that originating site fee of $20.52. Our CMOs reimbursed at a little bit higher rate. So if you think of it in terms of $1,200 annually, what is this going to look like? If 5 students are seen a month in that school system, they become budget neutral. So you're not looking at a whole lot to make this a budget neutral situation for them, and then anything over that, hopefully they're turning back around to their school-based health programs and their nurse programs. There are some challenges. $8,000 is a lot for a school system. Sometimes they choke when you tell them how much money it's going to cost them to get started. But we've been very successful in Georgia looking at creative ways to fund these programs. When we're asked to go into a school, the first thing we do is let's look locally. Who's available in your community that's already seeing these kids? Continuity of care is very, very important. And if the primary care provider is already in that community and they're seeing a large number of these children, let's go there first. Let's see if this provider either wants to come on site, does he want to connect, or she want to connect virtually. Let's start there first. Many times the local health system or local Rotary clubs or any other thing that's happening in the community usually are very willing to help set up these programs. One great example that we have the privilege of working with is Tift Regional Medical Center. They have funded many school-based telehealth centers all throughout the state. And these schools aren't required to see Tift Regional doctors. They can see anyone they want to. It's just a very nice way that they are giving back to the community and allowing this to happen. People support can sometimes be difficult. School nurses are some of the busiest people I've ever met. If you've not spent any time in a school nurse's office, I encourage you to go sit there for an hour. You will be astounded at what comes through their office. Some serious things coming through, and then, if it doesn't fit in anyone else's job description, it goes to the school nurse to get Sharpie out of a kid's pants or whatever it may be. It's amazing. So they are busy, and that is a challenge. A telemedicine visit takes approximately 5 minutes, 10 minutes, depending on what's going on. They're very quick. The school nurse has already gathered any needed paperwork, consent forms, already contacted the parent. Sometimes the parent decides to come on campus and be a part of the process. Sometimes they choose not to. So all in all, the appointments are about 5 minutes. Mental health takes a good bit longer just due to the complexity of some of the mental health conditions that they're seeing. So when that school nurse closes her office for a few minutes, there's a line of 10 or 12 students waiting when she opens the door. So that is a challenge. But there are many, many opportunities that far outweigh the challenges of school-based telehealth. And that is, in our network, there's approximately 150 different providers at any given time that sits on the GPT network just waiting for somebody to need their services. Primary care, schools do about 55% of their visits are primary care. Another 30% or so is mental health, and then underneath that is specialty care. Specialty care, we talk about sports physicals can be done virtually, speech language pathology. We've got a new program in the Perry area that's doing a great deal of virtual speech language pathology. And pulmonology, cardiology, anything such as that falls in that lower percentage. So there are many opportunities that these students wouldn't have, especially when you're looking at our rural areas, to see a pulmonologist or to see a geneticist or maybe even a mental health provider. So that is what it looks like in terms of school-based health, and I would like to open it up now to you for questions.
All right. Thank y'all. Very concise and very clear. We look around, Dominic.
Thank you, Mr. Chairman. It's odd, really, sometimes how we read things and they don't come back to us until you hear somebody speaking on the topic. But on the telehealth, I read a short article, particularly pertaining to mental health and psychiatry, where the three key components are diagnosis, doctor-patient relationship, and then therapy and treatment. Part of that article referenced the potential for a telehealth or a Skyping type of a communication between a doctor and a patient has some flawed patient relationships where the patient is not really developing a relationship with the psychiatrist. It's almost like they're talking into this virtual world of opening up their mind and their thoughts and their heart. And because we know so little about mental health, are you aware or familiar with any of that where some of these psychiatrists are concerned that mental health and that via telemedicine could create problems for the patient and from a liability standpoint? Are you familiar with any studies on that?
I'm not familiar with the studies that you're referencing, but I will clarify. There are lots of different flavors of telehealth out in the marketplace. There are a dime a dozen, and a lot of them are. You may not have the same psychiatrist every time. It just, you're logging on, whoever is available sees you that time, and it's really difficult to establish a patient-provider relationship at that point. We're a little bit different. We have a consistent panel of providers, so if you see Dr. whoever this week, the next time you log in to see your provider, it's going to be that same doctor. So continuity is very important. And all of our stuff happens in a clinical environment. We're not doing direct-to-patient home care where it's happening in the home. You're in a clinical environment. It's a hospital, it's a doctor's office, it's a school-based health center. So there is a professional there on the other end with the patient. Mental health is complex. Mental health can be very sticky and messy. So we have always felt it's very important to have a professional on the side with the patient. So if you have a suicidal patient or a patient really having a hard time, obviously, virtually, you can't put your arms around that patient. You can't close the door. You can't do the things that you would normally do. So we do see what you're talking about, and we try to make up for that in the model that we use.
Ms. Darlene?
Thank you, Mr. Chairman. Just a quick question. Logistics. I know you have electronic medical records. I would assume that's in most places. So your physician will actually be able to see the patient history or whatever information. Do they also have the visual? Is it Skyping where they actually see the patient, or is it just, not really visual, but just more for hearing?
No, it is definitely visual. We use a program called Pathways. It's a telemedicine software that our company developed. It has a tiny EMR piece in it. Our initial thought was we don't want to recreate the wheel. Most people have an EMR. We don't need to create a new EMR. But there's basic information that can be put in. If we think of school systems, they typically don't have a true EMR. So the school nurse is able to go in and put vital signs. She can upload files, upload images, anything that may be pertinent to that appointment. When the provider logs on, he or she not only sees that data that was input, but also has an actual live conversation with that patient and that nurse or the parent or whoever's in there. So, and there are digital exam scopes that are attached. So if the provider needed to look at the back of the throat or look at a rash or listen to a heart sound or lungs, they're able to do that in a live time. So the provider is seeing the patient, examining the patient, hearing the patient, and has access to any of the records that the school nurse has already preloaded. And likewise, if the provider needed to provide any educational documentation to the patient, maybe it's an asthmatic patient and they just need some educational material to go home, that provider is able to upload any information he or she has also. So when the consult is over, there's a nice summary note that the school gets to keep on their end. They can send it home with a parent or, whatever they want. The provider has the same summary note, and any of that material that were uploaded, those files that were uploaded, is also part of that file that can be printed off and sent home. So it's a nice transfer of information.
Could I follow up?
Oh, yeah, yes, ma'am.
Just another quick, I've read a couple things on it, and it seemed to imply that young people actually work better with the telehealth and telemedicine than older people because they're used to the computers and seeing somebody on a line. Have you seen that or found that to be true?
Yes and no. You would be surprised. We work in a lot of nursing home facilities, and on another day I'll tell you the stories about that. But it's not that big of a difference. It's not. As a licensed clinical social worker who worked in the school system as a guidance counselor for a number of years, I had a specific student with an autism spectrum disorder. Was completely nonverbal to me. I knew nothing about this child. 6 weeks into it, we log in and see the psychiatrist online. And I don't know what it was. She lit up and just talked and talked and talked and talked to the psychiatrist. I'm like, are you kidding me? I've been working with you for 6 weeks and you've not uttered a word. So in that case, it was a very non-threatening, very comfortable way for this particular child to interact with the technology, i.e. the provider. So I don't think it's just for young people. I think it can cross the gamut.
Thank you.
I want to just follow up with Chairman Taylor's question on medical records. Not a doctor or medicine guy, so I'm on the health committee with Chairman Cooper. Which means something maybe. But my question is, okay, so I think you said that they only I guess the evaluator, diagnostician on the end only has the information the nurse is loaded during the day. I guess this goes for Stephen, you too. You don't have access to if a child is seeing a pediatrician or a GP in Whitfield County Hospital, they're in Murray County, you don't have access to that. So you only know what little bit you know. How do you know what's going on the other end?
Well, there are a couple of things. We do have a health center in Murray County in Chatsworth. So some of the students are students that we see at the health center. Our electronic medical record system is housed both at the school and in our health center. It's all integrated. So if it's a patient of ours, then we do have access to all their records.
Just the records you have, but
Just
you
records that we
don't
have.
really have access to Epic or whatever the hospital in Dalton has. That patient might have also. I guess what I'm
Yeah.
getting at is they could be seeing two doctors. Or two healthcare providers. How do you know they're not? And divide that.
Sure. A couple of things. One is we don't have access to the records of a student who has an established relationship with a pediatrician who's not on our staff. In that case, we operate similar to an urgent care office. Right? If a patient has a need, on Sunday morning, mom will either take them to the ER, hopefully not, or to an urgent care center if one's available. And the physician on duty at the urgent care center will treat the cold or the upset stomach or whatever and send the patient back home. So we would operate very much in that same vein. The added benefit in our situation is that if we know who their primary care physician is, we will send records to that physician as a way to close the loop.
If I may,
Sure.
So we're in the early stages now of partnering with the Georgia HIE as an exchange, because I think that is an issue. It's hard to tell, and if we're not seeing that child's primary care provider, it is difficult. How many doctors are they seeing? So if we can work with the Georgia Health Information Exchange, and the school nurses can pull that information down, and the provider seeing that student can pull that information down, I think that's probably one of the closest ways that I can think of to start closing that gap a little tighter.
Go ahead, Terry.
I was just add something about the Health Information Exchange. We've been working, I serve on the board of the GM, and we've worked for years, and the ultimate goal eventually is that you will be able to have, to see everything that you need to see, okay? They're in the process now. We have agreements around the state, whatever, but and this is a kind of a national initiative, but ultimately, and I couldn't give you an idea of when it'll happen, but within years to come, a few years to come, you will be able to have access to the data that you need.
Yeah, Steve, kind of walk me through this. Let's say it's the first day of school or whatever. Okay, you've got all these potential patients or everything. You say that you have to have consent forms signed by the parent, right?
Yeah, correct.
Okay. How do you go about getting those consent forms?
It's a challenge. And so what we do is we provide packets of information in the information that goes to the parent at the beginning of the school term. And in that is a consent form and information about the services that we provide. And sometimes parents fill those out and return them. Sometimes they don't. If they don't, then we have a staff who makes phone calls to students, to parents, to see if we can't elicit to bring that into our organization. We don't get 100% compliance on that.
Okay. Now, and it kind of resonated with me. You were talking about the Heather situation. Believe
Yep.
me, I got plenty of Heathers in my district.
Sure.
All right, you said that you had a consent form from the student and from Heather and the mother or whatever. You said, but then you called her
We do.
to get consent. Is that a standard procedure, even though you have a consent form?
It's standard in our organization. I think that's what Dr. Johnson recommends as being standard procedure in all centers.
So you have a double mechanism of protection. You have
We
the
do.
actual form, and then you have her on the line. And then to follow up sort of on what Rick was saying about if they're dealing with another one, do you have anything like if the child is allergic to a medicine or things like that in the consent form? Do you get that, or how do you go about compiling that information?
So the school system will gather that information as part of their routine, and we have access to that.
Okay, so you are strictly relying on the school system from that standpoint.
Well, in the initial stages, yes.
Okay.
And
then
so
as it progresses, you actually add.
it does, yeah, absolutely.
All right, then one last follow-up, and this is just out of general curiosity. Normally, if you go to the doctor or something like that, I mean, obviously they treat your symptoms or whatever, but then they also go into prevention aspect and nutrition aspect maybe. I mean, I throw away $500 a year for my doctor to tell me to lose weight and reduce stress. I mean, but,
Yeah.
which hasn't worked yet. But anyway, do you have mechanisms in place when you're seeing the kids or dealing with the parents or whatever to like better nutrition or prevention or things of that nature? If a child is having an anxiety attack or whatever, you talk to them about how to.
Sure, absolutely. Our staff is skilled and trained for that. The top 5 reasons that we see children, number 2 is for dietary counseling. And so we pay attention to that a lot.
So you're very aware of that.
Absolutely, yes, sir.
Thank you, sir.
So can I come in on a couple of things? So routinely throughout the state, we require that the consent captures every health fact that pertains to the child. So allergies is like first and foremost. So we actually get that in addition to what the school has. We actually have probably 10 times more information than what the school has. So traditionally, that's what we do. The other aspect of our work really is about prevention, all right? And we've established benchmarks, quality benchmarks for these centers to actually make sure that they do, if a child is obese or if a child comes in for a health check, then you do all of those necessary preventative measures in order to make sure they remain healthy. And so it's like a tiered system where you're looking at prevention and intervention, sort of primary intervention and secondary intervention. So as I said before, it's like having a doctor's office in the school, and every aspect of, actually it's more than having a doctor's office in a school because most doctors don't have behavioral health, right? And most doctors don't have dentists. And a lot of these school-based health centers, you have not only a medical provider, but you have a dentist as well as a behavioral health person.
Thank you.
Chairman Parson, I saw you over there.
I know what you do. Oh, there we go. Anyway, Sherry wanted to ask you about the telehealth. I think Sherry, yeah. Just trying to understand this. So if I'm understanding this, any child in the school where you have this set up, obviously can go down to the school nurse. School nurse is paid for by the school system or somehow. But now as far as the telehealth part, when the school nurse has to contact the provider, does that include all the children or just the ones that have insurance, or how does that work? How does the provider actually get then reimbursed for his or her participation in it?
So when you're talking about primary and acute care with the local primary care providers, any student is eligible. Much like what Stephen was talking about, the consent forms must be filled out before a patient is seen. The parent is always contacted to verify that you really are giving me permission to do this. The parent is asked, do you have a provider of choice that you would like to see? You know, we tell them whoever's in the network that they can see, and they pick. And primary care providers will see students regardless. I don't know that I have an example of a time that a primary care provider denied a student care because of payment. When you get into specialty care, it's a little different. Sometimes they're not as willing to provide free care. Sometimes there's a financial aid program or something that the students can go, but that's usually not emergent care. It's appointments that we know is coming to set up 6-8 weeks out. The parent can work with whatever facility, maybe it's Children's Healthcare of Atlanta or Emory or Augusta or whoever they're going to be seeing to work out a financial aid plan.
Okay, but as far as the normal things, I'm thinking back, and suddenly I've gotten to the stage where I look around the room and I'm the oldest person in the room, so sometimes people can't really relate to when I was but I mean, I don't think I ever saw anybody. When I got sick, you were just sick. You didn't go see anybody in the school. But
You were raised tough there, Chairman Parsons.
that's true. But as far as just the normal things that a child might go see the nurse for, if she has to contact a provider through the then that's paid for somehow. They don't have the kid. If there's no insurance for the family, the kid they still gets provided for by the provider.
Right. I don't know of one time that a student has been denied care
Okay.
for primary and acute. And the way the workflow works, the student walks down to the school nurse's office. She does her normal everyday triage and uses her judgment. And if it's a case where she would have said, mom, dad, grandparent, you need to come pick your child up. They're running a fever. We need to send them to the doctor. We teach them to add a new little workflow, and they contact the parent and say, hey, your child's down here. This is what's going on. I see you've already signed up for telehealth. Would you mind if we saw a doctor virtually?
Okay.
And
Okay.
all the time, they usually say yes.
All right. Well, I appreciate it. Thank you.
Absolutely.
Chairman Cooper, please.
I have a couple of questions for different people on the thing. Used to, the major reasons that we were told children go to the doctor's office, Dr. Johnson, is for asthma and for dental problems. Or to the emergency room, the dental problems were a real,
Say that again?
is one of the major things that children have problems with, asthma and dental problems?
Yes.
Okay,
Yes.
so it's still a real major, so I'm glad y'all have the dentist. And what I want to know, we had a difficult time passing a bill a couple of years ago, but we got it through. And I'm wanting to know how, where you could have a dental hygienist without the physician without the dentist being in the building, could come in and clean children's teeth and do the preventive measure of putting the fluoride on.
Yeah.
Is that working?
Yes,
Okay.
it is. And actually, there's a center, Hollis Innovation Academy in Atlanta, just opened 2 years ago. They're actually using that practice to use their dental hygienist in the school-based health center.
Okay.
They also have a dentist, but they are using her for those services.
Right, but I mean,
Yeah.
because before, if they
had
could
to be-
only see them when the dentist was
Absolutely,
there,
absolutely.
you couldn't clean very many teeth
Right.
in one day's time. Now, if the dental hygienist can work 5 days a week, she can see a lot of children and clean a lot of teeth, which is preventive medicine like.
Absolutely. It's a real coup. Really appreciate you passing that bill because it really does help tremendously.
Well, we had a little trouble with the board, and I've heard that there's some problems out there with trying to get it utilized.
Hold on.
Huh?
That legislation has been a tremendous help to, our organizations, Fairly Qualified Health Centers, okay? And again, it has made the hygienists more effective and be able to use them really 100% of their capability, really. It was a great thing for us, and we've had some organizations have actually been able to expand their dental services.
Okay.
And it's particularly, difficult in rural Georgia where there are not a lot of dentists, whatever, okay. And then again, a lot of dentists, whatever, don't see Medicaid patients or whatever. But the dental hygienist legislation that was passed has been a tremendous help to us.
Well, I can tell you it took a lot of effort for a lot of people in this room and other legislators to get that passed, so I'm very appreciative of the ones that
Well,
stuck with it.
at the time that passed, my personal dentist was the president of the Dental Association. He was very, he was very supportive, whatever, because over the years we've talked, whatever. And actually, I was just talking to him a couple weeks ago before, I guess they had their annual conference, and we were talking, and he asked me how it was going, and I kind of explained to him, I gave him more detail, whatever, but he wanted to give a report, to the conference, whatever. And again, it was very favorable, very positive.
Good. The other question I have is for Ms. Williams. Well, first of all, do you have actual data on the utilization of how much it's used in the schools? Also, what about scheduling and, the wait time? Like, okay, you've got so many doctors and, you've got all these schools. What is the average if a nurse feels like a child needs to have a doctor's visit virtually? Is it almost immediate, or
So in terms of primary and acute care, that is a very quick turnaround. Typical wait time is 30 to 45 minutes. The providers just work them in as if you were walking into their office as a sick patient. So that's very quick. Mental health, there sometimes is a wait time. We have a shortage of mental health providers in our state, and this is not unique to Georgia. It's everywhere. I had a call with Nebraska last week. They're struggling with the same thing, and they were hoping we had access providers. Like, I don't have any either. We struggle. When you look at mental health, there is a wait list. Some of the other specialties, just typical, maybe 3 or 4 weeks before your appointment comes around. Mental health can sometimes be 8 weeks or plus, just depending on what it looks like. Utilization varies from school to school. We don't dictate to the schools how they need to run their telehealth programs or how many appointments they need or that type of thing. So it really depends on what's going on in that school and how busy that nurse is and how available she is. And, when you're looking at flu and strep throat season, you see utilization go up pretty well. But, the beginning of school is always pretty slow. The middle of school, Christmas time really peaks. And then, toward the end, it kind of goes off again in terms of those acute care. Mental health appointments happen all through the school. Those are very consistent. But utilization varies from school to school just depending on what's going on.
Okay, and last question. This is very timely. I just had a conversation with Dr. Toomey, the new Commissioner of Public Health, and trying to provide more access to health, which is a real passion of mine, across our state. And we have a public health department in every single county, all 159 of them in our state. And a few of them are doing a good job seeing patients, but a lot of them are not seeing patients. Is your company, if I remember correctly, the one before it became so global and is now considered the #1 virtual, and I don't work for you, and I'm sorry, but you do have the reputation of being the #1 provider across the country and international, I hear now. Is your company the one that was ready to help us load up and do telemedicine about 10 or 12 years ago through public health, and then somebody in public health decided that they could do it better themselves, and we have no telemedicine really in public health? So your company? I sure would hope that I hear that didn't end well. I would hope that maybe if Dr. Toomey wants to explore that avenue again, you'd be willing to talk to Dr. Toomey at Public Health.
And I would just let you know, if I may. So Department of Public Health is one of our strategic partners. We do a lot of partnership with them. They have their own protocol, and there are some of their own policies that they have to work through. We've always been very willing partners with them. Salima Salgado is the head of their telemedicine department. She is a counterpart to us, and we have weekly calls with them. Some of the health departments, they say telehealth, and sometimes it's maybe a WIC program where it's an educational thing. Telemedicine is a little different when they're actually, seeing the patient for care.
Right.
There's several health departments, and one that I'm familiar with just because it's in my neck of the woods, the one in Valdosta. They do a large number of patients virtually. They connect to Children's Health Care of Atlanta and Augusta University for pulmonology, and I can't remember what the other services are. So there is a lot happening, and they are definitely one of our strategic partners.
Okay, but we're not utilizing it in full capacity.
I think in the health departments that have the capacity to do the full patient exams, I think they are being used. I don't know, and I don't want to speak on behalf of the Department of Public Health, I don't know that every single health department has the equipment needed to do the full patient examination.
Okay, so maybe that's where we've fallen down then. Things have moved along and we've fallen down in supplying our public health departments with the machinery. Like you say, that $8,000. I mean, it costs money to buy a machine where you can do a sonogram or you can check the ears and the nose and the heart and so forth, that initial step. Okay.
Absolutely.
Okay, thank you very much.
Chairman Houston, please.
Just want to let you know. Did I do that?
Look at me.
Okay, I was going to really give a shout out for Sherry Williams. She brought telemedicine to my county many years ago, and we have had telemedicine in our school for how many years?
We opened up the doors in 2010. That was the very first telemedicine program in the state of Georgia in the school system.
And it was in Berrien County, the very first one. And I tell you, we've had no problems. And, you know, if somebody had been unhappy, I would have heard about it. And it's just been nothing but a pleasure to work with y'all. And thank y'all for bringing it to us.
Thank you very much.
Then we get Chairman Reinders, then Butch.
Thank you, Mr. Chairman, and welcome. I appreciate the work you do. I work with Chairwoman Cooper closely on that dental bill, and we had to look at things like unintended consequences. So we amended the bill to make sure that a dentist group outside of Chattanooga wasn't coming in, and we wanted them to hang a shingle that being from Georgia. That said, we also are asked quite often about changing scope of practice for things like nurse practitioners. We talk about the statistics of the number of counties that don't have primary care physicians. With that said, what I am concerned with is making sure that we don't have the unintended consequences that we may be creating an environment with access that might in fact keep a primary care physician from coming, and we're trying to find in health where's that balance. It is not your job, since you reference we don't have a pediatrician. You have to be concerned with, if we're too good, we may actually not get a pediatrician coming into this county. What kind of model do you use to make sure that our unintended consequences means we don't get a dentist or we don't get a primary care physician?
And I spoke to our model earlier. We look what's locally first. We call it the local scavenger hunt. We want to make use of everybody in that community. We don't want to skip anyone. Telehealth should never be a tool that takes patients away from somebody. It should be just an enhancement so that everybody has easier access to their own primary care doctor or their own specialty doctor or mental health doctor. So never do we encourage telehealth to be used to bypass the local medical community. I live in rural Georgia. I live in Berrien County. Our providers, Cook County the same way, our providers are gold to us. If someone came in and circumvented those practices and those practices had to go out of business because patients were no longer coming to them, that is a huge tragedy for rural Georgia. Telehealth should not do that. School-based health should not do that. We should support the local medical community that is existing. So that's our model.
Let me rephrase. If we had a county that was 14,000 people, hypothetically, and you're just sitting there trying to figure out, is that large enough to support a dentist or large enough to support a primary care physician? I just don't want the unintended consequences, because we've put in access in place, which we need to have, that may be the exact reason someone goes, I'm not coming to Blakely, as a hypothetical. How do you find that balance? It's not about the telemedicine. It's about, I don't want to do anything that might keep a primary care physician from coming.
Yeah, I can answer it from a Murray County standpoint. Is we didn't see having a school-based center with a nurse practitioner as replacing a primary care pediatrician. In fact, we hired a full-time pediatrician to work in the county after we had the school center up and running, because we felt that we needed to have that specialty as part of our organization. So we expanded access with specialists in pediatrics and nurse practitioners by a factor of 2. So.
And then finally, is there a model that you have when you look at, did you reference Teleferro County?
Taliaferro County?
Yes, ma'am.
Yes.
Or a Clay? I think we have a primary care physician in
Yes.
Clay.
No, Randolph.
I'm sorry?
You mean primary care or school-based health center?
I think we have a physician, a lady that Gerald Green is very proud of in
Yes.
Clay County with 2,700 people. And so is there a model of a system that would be too small, that it wouldn't be cost justifiable for y'all to go in there and operate? Do you have to have X amount of students?
Well, you have to have X amount of children, all right? So the students, we also see not only the students, but also their siblings, right? So, so those are the counties that you really kind of want to target a little bit because no
Right.
one's going there. I just want to comment on sort of the model when you're talking about displacing providers. When I talked about the planning grant that we do, we actually bring the community together so that they can sort of define what their needs are, right? And then we pair them with whoever is in their area, whether it's an FQHC or a hospital system, or in Muskogee County, there is a charity organization that does it, all right? And so it's really the community's decision about whether or not this is a good fit for them, right? When you're talking about counties where people have not gone into, they're not going to go, they're still not going to go into it, whether there's a school-based health center there or not, right? Because we've been battling with these counties since the inception of time. So we actually focus on those areas that have high need and have low providers. And it really works real well, especially when you bring the community together and they decide what it is they need to do as far as creating this system of care for children. And I just want to say a couple of things about the difference between our model and telemedicine. Our model really is the more comprehensive model that really sort of addresses every complex health and behavioral health needs of children in a very integrated way. I think telehealth is a great adjunct to what we do, but it really is not the model that we sort of promote in the sense that it really doesn't have the scope or the capabilities to address the really complex needs of a lot of these children, and especially in the rural areas where they have so many more needs because of all of the issues that they're dealing with, especially around poverty. But I think working together is a great way to sort of network the state to make sure that we actually identify those areas that have those gaps in care. And one of the things that I really want to see happen in our state, we have a lot of resources that we haven't tapped into. We got hospital systems, we got FQHCs, we got private doctors, and we really haven't come together. We have health departments, and we really haven't come together as a state to see where we can actually create a network of care for all of our citizens and really sort of branch out. The reason I love school-based health centers in the really small areas is that you take an FQHC like Stevens and you place a satellite in the next county that may have absolutely no one, and they're part of that large system that he owns. I think everything needs to work within the context of a larger health system, not in isolation, not one doctor doing one thing and one doctor doing another thing, but everybody taking a look at the state and really come up with a plan where we can actually infiltrate the state with the healthcare services that we need. And we really hadn't done that as a state. We've been working in isolation of one another. And I see school-based health centers as a way to link all of that together.
Thank you. Mr. Chairman, I just want to
Sure, go ahead. That's
I just want to say to the committee, you know, we look at things like loan forgiveness, going in serving in rural areas for X amount of time. We've discussed those kind of issues when it's health care, and I just hope that we find the right balance to provide access, because that's what it's all about. Thank you so much for what you do.
Sir. Chairman Parrish.
Thank you. Excuse me. Thank you, Mr. Chairman. First of all, I want to say that the people sitting at this table and other members of the House have really been an outspoken advocate for the federally qualified health centers and the establishment of those. And with those, some 34 organizations, 225 sites or whatever it is, and I forget how many counties, 125 or 30 counties or something. But a couple of questions that I wanted to get y'all, we've talked about it, but maybe elaborate a little bit more and help me to understand it, and I think maybe it might help most of us understand it better. First of all, who mans the clinics? I know in an FQHC, you have your own providers, as I understand it. And maybe in the telehealth system, you would use other providers and sometimes nurses or whatever. So could y'all talk about that just a little bit? And then also the question was raised about who pays and how the reimbursement occurs. Could you talk just a little bit more on that from the aspect of the FQHC side or the school-based clinics, and then maybe the telehealth too, to help us get a little clearer picture of what's going on?
So the comprehensive school-based health centers that I'm talking about have a medical sponsor. The school system doesn't, there's no cost to the school system other than the fact of overhead, and it really doesn't cost them any extra because they have to keep the lights on no matter where the clinics are in the school. And so the medical sponsor, which is usually an FQHC who we partner with, over 90% of the school-based health centers in the state are the medical sponsors are FQHCs. And we think that's important because they have the ability to sustain themselves. They get enhanced Medicaid reimbursement, and that's where the payment comes from. They also do sliding scale, but for the most part, their mission aligns with ours, taking care of underserved families throughout the state. And so they're responsible for the staffing, for the cost, for the liability, they really assume all of that responsibility, no matter who the medical sponsor is, and it's never the school system. It is the separate medical entity that serves as the medical sponsor for school-based health centers.
Each organization has, medical staff, and in a lot of cases in rural Georgia, we do use physician extenders, nurse practitioners, or PAs or whatever, but they are employed by, the local organization or contract. In some cases, they're a contract person, whatever. But, they, with regard to coming back to the earlier question too, with regard to telehealth or telemedicine, looking at a primary care program, taking the school-based, putting that aside, just looking at the general practice of an organization like Stevens, primarily what you're talking about is their primary care docs tying into a specialist, whatever. Somebody down in Waycross, talking to an ear, nose, and throat specialist up in Emory, as an example, whatever. So it's not, they're not taking the place of primary care doctors. Okay, they're, each organization, manpower in rural Georgia, as you know, is one of our major problems. I mean, finding doctors, whatever, and finding nurse practitioners or PAs, whatever. So it's a constant struggle. It's something we're always working on. But the telehealth or telemedicine, situation is a help, especially in rural Georgia with regard to specialty care. Okay, I mean, it's a way. I saw a demonstration years ago when Paula was more active, whatever. Where they had a patient in Waycross, whatever, tied in to an ENT doctor at Emory, whatever, and basically we're sitting there in the audience, and it was just like we were there in the room, with the provider down in Waycross, whatever. So the specialty care is really important for us, for our primary care practices.
So in the telehealth model, the school nurse is typically the traffic controller. There may be a coordinator that works with her. But in terms of who delivers, who facilitates the appointments, it can be the school nurse, the school social worker, the guidance counselor, just depending on who the student is and what the case is. In terms of reimbursement, Georgia should be very, very proud. We were one of the first 3 states in the nation that passed telehealth parity law that makes reimbursement very, very easy. As we've progressed over the years, Georgia has done nothing but make our telehealth laws better. So reimbursement is dollar for dollar, the same amount. If I walked into your office with the same CPT code and you were able to see me virtually, it's dollar for dollar, that same amount. So we're a very telemedicine friendly state.
Good. One of the things, Mr. Chairman, I've come to conclude, this group that you're a part of, we've been very aggressive in putting the seed money in to help the FQHC's federally qualified centers get started. But we had a real focus for a number of years on primary health care, which obviously is very important. If you don't have that, you don't have anything. But I've also, over the years, I've come to the conclusion that we were only halfway there. We have started to do now to put money in to help start the behavioral health side of this. And really and truly, you got to have both the primary care and the behavioral health, because we were only addressing about 50% or less of the problem that we had. So in the future, as we move forward, I think we need to keep that in mind, that we need to address both the primary and the behavioral health care, and I'm sure we'll have the opportunity to talk about that some more.
Yes, sir. Chairman Emeritus Powell.
Thank you so much. I won't tell you what I said, told Terry England what emeritus meant in Latin, but it was not complimentary.
He's red. I don't think so.
Because he was afraid I was going to say the word. I've been really intrigued by what y'all have done and what's happening in the state. And especially Stephen's comment, which I think is probably true of everything y'all have said, which it is a win-win-win situation for everybody. And so my question is, and one of the things that we do on this council is we try to determine what are the barriers to economic development, health care, whatever it may be, in rural Georgia, and how can we remove those barriers. So my question to you is this: why isn't this happening in every school in every rural area or throughout the state of Georgia. What are the barriers that are keeping this from happening? Like Chairman Cooper mentioned one barrier that we've removed, which dealt with the dental health care, and by statute, we've now changed that so that that barrier is removed. But what other barriers are there to keep this from happening everywhere? And, you know, it might be that the insurance companies need some encouragement to, you know, pay for telehealth or whatever it may be, because if I see a doctor and I get care, I don't really care whether I'm physically in his office or, you know, in some kind of network, but sometimes, you know, insurance companies may see it differently if you don't have a physical visit. So tell me what the barriers are that we can help with.
So you've stated the obvious barriers. Obviously, funding is, I think we would all shake our head and agree. We all need lots of funding. Staff is very, very important. But if you look at the, you know, kind of underneath, there's a lot of attitudes. You know, we run into a lot of attitudes. Maybe the school district or the community says it's the parent's responsibility to take these kids to the doctor. It's not the school's responsibility. We don't need a doctor on site. I beg to differ. A lot of times children aren't seen not because the parent is neglectful, they don't have the means to take care of the child. So, you know, we can talk about the obvious stuff all day long, but I think there's a huge education piece that we're missing. I think we need to really get to the heart of the matter and figure out in these counties where these services are not happening, whether it's virtually or in person or whatever it looks like. Why is it not happening? Is it an attitude? Is it a lack of understanding? It is a, you know, what is it? And a lot of times I hear over and over, we're not going to provide this service. It's the parent's responsibility. Okay, I'm a parent all day long. I use school-based health a lot with my children. I am not a neglectful parent. Sometimes I'm up here in Jasper and my kids are down in Berrien County and somebody may have strep throat and I need to get them seen. And school-based health is a wonderful way to help me as a parent to take great care of my kids. So I think there's a lot of education. I don't know the answer. We've struggled with this for a lot in our company. What is the best way to really start educating the communities on school-based telehealth or school-based health? So we can start getting rid of some of those excuses that people come up with over and over and over. Even some of the schools that have been funded and you know they have telemedicine, some of them just refuse to use it. They just refuse to use it because it's not my problem, it's not my responsibility. I will argue until I'm blue in the face all day long that it is. So I think there's a big education piece of it that we really need to look at and how we get the word out that it is important for the schools to really supplement what the parents are able to do.
So when we do the planning grants, that's usually the initial barrier, but by the time we finish the planning grant, it's no longer the barrier as far as education, because there's a whole purpose. Is how do you convene a group of people together to first define the needs of their children and then come up with solutions. And we find that when we do that, in all the counties that we've done them in, then everybody's on board. Unfortunately, and I'm ashamed to say this, some of our greatest barriers are our pediatricians, right? My colleagues. And it's because oftentimes they don't understand. And so I've spent a lot of time trying to, I'm part of the Georgia Academy, the Georgia chapter of the American Academy of Pediatrics. I chair the school council. I've done presentations to them. And I'm bringing them around slowly. But sometimes they'll undermine you because they think maybe it's competition. Sometimes they say, well, you know, the quality of care, we're not so sure about that. But once you go into these communities and you have these, and it takes a while. It usually takes about a year to really to bring everybody together and to educate them and to get them to be on the same page. Everybody agrees that this is the best way to go, especially for underserved children. You know, there are 2,200 schools in this state. We're not going after every school in the state, right? Because every school in the state really, they could benefit from it, but they really don't benefit as well as children from underserved. So our target are those children at greatest risk, right? And then when we present that to these pediatricians and other providers in the community, then they usually come along and say, okay, this is all right. The school systems that we've spoken to want it. Matter of fact, some of our planning grantees, applicants, they're all school systems. And they're like beating on our door trying to, how do we get this into our school system? So it is about educating, but it takes a while to do that. And it takes dollars to do that because we fund these people, right? And so the barrier of funding is always there. One of the goals that we wanted as an organization was how can we get the state to sort of underwrite some of the planning dollars that really go into this whole process.
I want to respond from a behavioral health standpoint. And I think the issue comes down to lack of professional resources and reimbursement. I have a school system in a different county that came to us and said, we have at-risk children that we've identified from a behavioral health standpoint that are at risk. We can't get them into a behavioral health specialist to take care of these kids in a timely fashion. Can you help us? And we said, well, we've got a psychologist and we've got LCSWs on staff. Come in and see us. And they said, no, we want somebody at our school system, or we want to have a fast track so that we get priority for our students. They came to us in part because there's a lack of professional resources in the community. So I think somehow we need to work on that. Secondarily is, as a FQHC, we don't get reimbursed for the full range of specialist counselors that are able to provide care to students, right? So, for example, LPCs. We are not able to bill and receive reimbursement for LPCs. So if we had that, then the ability for us to hire additional professionals would be enhanced.
That's state or federal law?
I think that relates to the Medicaid program.
Coming back, there's a big difference of opinion around the state in school districts, based on my experience, okay? And everybody's kind of talked about that. Where we are in a school district, if you talk to the school, they're happy. I mean, they're glad we're there, whatever. But some people are just slow to move ahead. I talked about our positive experience down in Tulliver County. The school superintendent there, Alan Ford, whatever, I kind of joked with him. I said, we need more people like you in other school districts, okay? And actually asked if he would speak on our behalf if we were trying to go into a particular school, which he's willing to do. So I guess perhaps one suggestion I would make at some point in time, let's convene all the different school districts, whatever, and talk about healthcare, school-based clinics. It might be a step in the right direction. You might win some people over. You're not going to win them all over, but you might win some people over. But my experience, if you get somebody like an Alan Ford, like a school superintendent that's got a great, he's the one, really, again, he's the one that suggested let's open it to the whole community. Let's put it out on the property, and we open it up. It was I just have to give him a lot of credit. And again, he's the kind of guy that's willing to step ahead and talk to his peers around the state and say, look, this is the right thing to do. It's a big help.
To answer your question, Mr. Powell, good deal. I hope the committee doesn't mind. We're running long. I think it's a great discussion. I know there's some other questions kind of here. Vice Chair Corbett.
Thank you, Mr. Chairman. I'm going to build on what Chairman Powell talked about, some of the challenges. But first, as we address the healthcare issue in rural Georgia, I think telemedicine is going to be a huge piece of that puzzle. But I was reading an article last week on telemedicine, and it's talking about one of the challenges that they were seeing was licensing, with being able to, I guess, work across state lines, if you will. Do you see that as a problem? And can you speak to that?
I actually see that as a double-edged sword, and this is just the world according to me. So I will tell you what my opinion is on that. I think it is wonderful if we can have a state compact. So if Georgia is not producing the type of provider we need, it would be nice to look at some of the surrounding states or California or wherever it is and have those doctors be able to come in. My concern is oversaturation of medical providers, and we start to dilute the services that are there. Our goal as a company has always been to support rural Georgia, and if we circumvent those rural providers and supplement them with other doctors coming from other states, what does that do for that local economy? That's the part that worries me. I do think in terms of mental health, some specialty care, I think bring it on. We can't take care of our own need in this state, so I think the supply would be nice. It is a challenge, and I think we have to look very, very carefully at what that means for economy versus patient care versus all the other factors that go into it. We're talking about consequences earlier. I think we need to look at the positive and the negative consequences of that very carefully.
Mr. Floor Leader.
Representative Perkle and myself and Senator Harper, U.S. Senator Perdue, Congressman Scott, we met with South Central Primary Care, one of our FQHCs. And Senator Perdue did an unbelievable job of talking about how important the FQHCs are going to be to access to quality care, et cetera. And so I am in total agreement. The more of these meetings that we attend and have the opportunity to spend with our FQHCs, because of of how they're able to do it in these small population counties or communities is just unbelievable. But one of the most recent reimbursable codes that we've had come because of innovation and technology is remote patient monitoring. And I think telehealth is probably going to be able to participate in that with helping physicians or FQHCs to get some reimbursement for that. And there's other remote patient monitoring companies based right here in Georgia that's ready to do it with 4G capability on iPhones and tablets and actually put remote patient monitoring into Sycamore, Georgia. Turns out half the powerful people in Georgia are from Sycamore. Who knew that? But I've been working with a couple of different groups, but it's going to take you helping us to convince these physicians that your remote patient monitoring companies, whether it's telehealth or the other companies, they literally do, you got to have like 16 connections with that patient within a certain period of time to do these reimbursable codes. And I think it's $125 after they do the equipment, the setup, and the patient contact. So I'm excited, but we may have to, and I think Chairman Powell alluded to it, I know Chairman Reinders did, we may have to look at some scope of practice obstacles. And I know that's a touchy area. But following up on what Chairman Reinders said, I'm not so much concerned about there not being a pediatrician there as I am concerned about the care being there. And so if we're providing the quality care to those children or to those communities, that's my number one focus, not necessarily whether there's an office with a shingle hanging out front that says, you know, this is a pediatrician. So I don't know, that may not be popular, but at the same time, that's the reality that we live in.
Well, you know, quality is, I mean, you all you have your family practice doctors, whatever, and some of you may have noticed that they're changing the way they practice medicine now. It is about quality. It's about outcomes. It's about you coming back, you know, on a regular basis for checkups or whatever. And the one of the end results, there are two results, is you stay healthier and you can nip something in the bud perhaps and you know, live a lot longer because you caught something because you're going back on a regular basis. And then the second part is you cut down on costly hospitalizations, whatever. You know, you keep the patient healthy. So that's part of what we're all about. I mean, one of the things that we've been involved with for years is called the Patient-Centered Medical Home, program, whatever, okay? Our goal is to get people to come into the practice and have them keep coming back to the practice. And this gets back to your original question a long time ago about the mental health providers, you know, the connection. What you get in a situation like that is you get a better connection. They know the people, you know, they're regulars, so to speak, and they're coming back, and they're familiar with our social worker or whatever, so that the social worker that they may be talking to a psychiatrist in Atlanta, at least they've got a relationship, and that's going to help the patient, you know, accept that psychiatrist on the, you know, receiving, you know, on the other end of the telehealth number. But the key is outcomes. You want to have quality, whatever. So looking at companies like you're talking about, there's a reason to work with them. Yes, I mean, in the end, they're going to help save money. And so, you know, we're interested in looking at anything like that that's going to help.
We're gonna move to another. He answered it. Let's move to
okay.
Representative Martin.
I see the fact, and I'm from the metro area. I'm sorry. I'm from the metro area, but I've been out of state, don't live there, but I understand what's going on. And it seems to me we get in this quandary between the care the people need and that technology is allowing us to deliver, and then on the other hand, but we want to be careful we pay the right doctor. I mean, I get both. I hear what you're saying. But it seems to me it's simple. If we really want to deliver this, and I'd comment on this, please, is it not true if we would let doctors and medical professionals, I'll just go with medical professionals because there's a lot of people that don't have an MD by their name that can help us. If we let medical professionals practice to their level of education and certification and got the regulations that we impose, sometimes at the bequest of the professional organizations, out of the way, would that not help healthcare get
to rural Georgia faster. If we let you practice to the level that you're educated and certified by your professional organizations and get the regulation out of that way, would that help, whether it be through telemedicine or telehealth or getting people to practice in these rural areas?
So I sort of understand what you're saying. I sort of don't understand what you're saying. I think we all sort of practice.
Let me use Chairman Cooper's thing.
That's sort of like where we are with it.
Let me use Chairman Cooper's example.
Okay.
Dental hygienists are educated and certified the same in Georgia as they are in states where they were able for years to practice with indirect supervision. We had a situation in Georgia where it required direct supervision because we regulated them to do that. And by that, as Chairman Cooper said, we kept care away from people for years and years and years. So that's a silo example of a larger question I'm asking. If we remove some of those regulations, would it not help you get care to people sooner?
So I think as a medical provider, I don't feel bound by any regulation that you've imposed upon me. I think I can practice wherever I need to practice without any limitations on that. When you're talking about ancillary services or advanced practice practitioners like nurse practitioners and PAs, there may be some regulations that are in place that we need to look at that prohibits them from working independently. So for a long time, PAs had to work alongside a physician. But we sort of changed that a bit. That's not necessarily the case. And there are some conditions, and I'm not quite sure what the law is, that allows certain PAs to work independently, not independently, but separately from the physician so long as they have access to the physician. The nurse practitioners, they have other guidelines, right? So I agree there are some regulations, but it still requires, you're still talking about putting a body in an area where you're really struggling, right? And how do we find ways to entice people or to make someone part of a larger system that would be more palatable for them to go into a smaller area. I think one of the biggest reasons a lot of people don't want to go into rural areas because they're by themselves. And when I left residency and started practicing medicine, I was in Mississippi, Meridian, Mississippi, the only pediatrician, and I was by myself. And I was a bit, concerned initially, but I realized that I had the qualifications to do so. But I think a lot of people just don't want to be the only one or be isolated. And that's why when I was talking about creating a network, an infrastructure where we have larger systems that really are branching out into these rural areas, we'll have a better opportunity to serve more people in these areas and put people where they need to be.
Okay, time.
It may be something.
I said time. Whoa.
It may be something.
No. Turn this microphone on. Chuck, they'll be glad to talk to you afterwards. I know you'll hang out, but we are 30 minutes running behind, and I've got other speakers and that we need to give them their due too. Let's give these folks a hand. We appreciate it.
Thank you very much. Thank you.
You're welcome. So I'll stand up just a minute while Commissioner Fitzgerald, where you at? All right, come on up. We'll stand up a minute, like yesterday. If you need to go to the restroom or something, but I need to stretch my legs for a second. Good deal. You got our, hey, Jude. All right, let's round it up. Have a seat. Thank you, committee, for giving us the leeway right then to have that great discussion on health centers and clinics. I think it's very beneficial to everybody. And so we've got someone next who's known by all, and especially in this room, that's interested in health and mental health and all sorts, is Commissioner Fitzgerald. And we welcome you to Jasper and the Rural Development Council. And the floor is yours, ma'am.
Thank you so much. It's really a pleasure to be here. So I'm Judy Fitzgerald. I have the privilege of serving as the Commissioner of the Department of Behavioral Health and Developmental Disabilities. Let me pause. It doesn't roll off your tongue, I know. But I want you to know, y'all have asked me to talk about a couple of things today. So I want to make sure I cover those. And then it seems like I should leave lots of time for questions. And my partners here are going to help me answer questions too. The most rewarding part of being here today is not just this cool building that I've never been in before, but I'm a social worker. Been in the state for about 25 years, and I very clearly remember a time where if you told people I was going to come and talk about mental health, it would have been a pretty empty room. And now, really because of the interest and really because of the support that you all have shown to our agency, our providers, and the work that we're doing, we really are in the midst of a necessary and really important transformation, particularly in mental health, behavioral health, and for serving people with intellectual and developmental disabilities too. So, in case you don't know who DBHDD is, I think I'm going to tell you a little bit about it. Let's see if I can get my technology here. Am I pushing the right button? Seems like the one with the arrow should. There we go. All right. When I talk about DBHDD, one thing I want to be really clear about so y'all know what we do, know the responsibility that we have, and really the mission that we embrace at DBHDD. We were created as our own agency in 2009. So really it's only been 10 years that we became an agency of our own. And what you see there is a figure. Formally speaking, we serve over 180,000 people in Georgia. And that's just the number we count. We touch a lot of other folks that we don't count in this official count, but I'm going to say a little bit more about that. Most clearly, I want you to know what our department is responsible for. We are the agency that provides treatment and support services for the most in-need folks all around the state in 3 disability areas in particular: mental illness, substance use disorder, and intellectual and developmental disabilities. Anytime I'm using language or words that are our words and don't make sense to you, please feel free to pause me because these are folks in your community in great numbers. And many of you know this, but I also just want to make it clear, we are the safety net in your local communities. That's our job. It's what we want to do. The most difficult and most challenging individuals are who we aim to serve. And you see it there on the slide. Our priority population are individuals who are uninsured, underinsured, and receiving Medicaid. And as you well know, in our state, particularly that uninsured is a high number. And people who are reliant on public services is a large number of folks. So this is who we, as a department and our network, serve. Okay, oops. Sorry about that. Going the wrong way here. I'm sorry. Okay, quick snapshot, because I want you to see the totality of our system there, kind of packaged onto one little slide here. The headquarters of DBHDD is in the state office that y'all are familiar with, right around the corner from you at 2 Peachtree when you're in your capital mode. And then our state is divided into 6 regions that you see there. And then the anchor of the public safety net are our community service boards, which touch every county in the state except for 2. The 2 exceptions are Fulton County and Habersham, and that's because 2 decades ago they decided they didn't want to do it that way. That's a different story. I really want you to focus on the majority of the state is covered by your community service boards, and they cover every county in the state. We also oversee the 5 state hospitals. And you see the locations there. What many of you know is that before the settlement agreement with the Department of Justice, we had 7 state hospitals. We have since closed 2. We are now down to 5. We have no plans to close any future hospitals. I can say more about that later. Another way, I want you to just get a quick snapshot of, of DBHDD is to think about us as just a continuation of the conversation you just had. Because really, we are in the healthcare business. So who we are is we are a $1.3 billion agency, and that is largely state funds. You all are allocating the funds that serve our safety net in this state. And that tells you what the need is because we're spending every dollar, really, in order to get services out through those hospitals and in your local communities. We have about 5,300 employees at DBHDD. About 2/3 of those are in our hospital system. The rest of them are in the regional office or the headquarters. You noticed we had the 6 field offices, our 5 state hospitals, the 24 community service boards, our partner in the public safety net. And then I'm going to spend a minute more, but if you don't know about it yet, I absolutely want to make sure that you know you are funding one of the state's most critical resources, which is GCAL, the Georgia Crisis and Access Line. And you see the 1-800 number there. If it's not blazoned in your mind, we'll find ways to make sure that it gets known to your communities. We are funding something that not many other states have. It is a 24/7 crisis hotline that anybody can call for any reason related to mental health and other social service needs in the state. I'm going to talk a little bit more about GCAL. But the thing that I want you to know, so how do we do our work? As I mentioned, we have the 5 state hospitals, but when you give us the funds, we allocate those out into the community. So our 24 community service boards are the anchor of the safety net. In addition to that, we contract with providers all throughout the state. And in our network, we have approximately 255 behavioral health providers and about 423 providers of services for people with intellectual and developmental disabilities. So not only are we an anchor in your community for the people that we serve, but our workforce, each one of those agencies, those community-based provider agencies, has employees, really, and a mission in their local community. So we are vital members of your community, and their contract with DBHDD, for a lot of them, that is the main source of the way they do business. Okay. This slide is in here really just so you have it for reference. If you're not familiar with who your community service board is, I should be talking to them because they should be reaching out to you. Our community service board leaders are highly dependent on their local communities, but you see within our 6 region, each of the community service boards has a designated catchment area. They may do some work outside of that catchment area, but it's a defined, they are responsible for providing those safety net needs. So I want you to have that map as a reference. It's on our website too, but just in case you don't know. And then one thing, over the course of time, all the community service boards used to have names that made it easy. I used to work for the Gwinnett, Rockdale, Newton Community Service Board. That made it a little, did not roll off the tongue. They've changed their name to Viewpoint Health, but I want you to know, just despite the name change, it hasn't changed that they are the local safety net in your community. Okay, so let's talk about the Georgia Crisis and Access Line for a minute. This is an award-winning and vital resource because there are national hotline numbers, but there are hardly any other states that have made an investment to have a 24/7, 365 days a year that is staffed with licensed clinicians. Anyone who calls. You can call for yourself, you can call on behalf of a loved one, you can call if you don't know how to tell somebody where they might look to go for services. That phone will be answered on the other end by a licensed individual who can, in some cases, guide somebody through a clinical crisis. We have a lot of stories of people being talked off the ledge, as you would anticipate. We also, in that conversation, when it gets to a point of crisis, we also can deploy mobile crisis. Okay, this is how mobile crisis gets deployed in every county of the state. We contract with the mobile crisis providers. They are available in every county of the state. We used to have 2 mobile crisis systems, one for people with behavioral health issues and one for people with intellectual and developmental disabilities. And about a year ago, we changed that. You know why? Because you shouldn't have to figure out if someone is in need what their primary diagnosis is, right? We should be getting to the place where people in need help and showing up and bringing live resources. When needed, we partner with local law enforcement if that's what's required in the situation. We hand these cards out wherever we can and try and make it possible for people to know how to reach us. So, and the phone line is only one way to reach us. And I want to acknowledge Chair Dempsey and her former staff person, Leo Chansey, who's also in the room, who were vital in helping us build out one aspect of the 1-800 crisis line. What is it that you all know about teenagers? Do they like to pick up the phone and chat? Not so much. Even from my daughter's bedroom upstairs, I can get a text about what's for dinner. So they do not want to call, right? What they want to do is they want to get on their phone. And really with the foresight and the leadership and your support, and I really want to commend GCAL and Behavioral Health Link, the company that does this. They had the foresight to become accredited to receive texts for youth, for anybody in crisis. Primarily, it's adolescents and young adults using that texting function. But we now have added an app. It's the MyGCal app. And if you download it onto your Android or your smartphone, all you have to do is hit that, and that connects you immediately. We're finding out some really interesting things. This has only been up and running for a couple of months. We're finding out some really interesting things that, and I think you'll find this interesting, because we are all concerned about adolescents in crisis. Sometimes we're concerned about the ones that we see, it's visible to us are in crisis, but really what we find is that sometimes for youth that are depressed, folks don't know it, and they're struggling. And what's happening is the time the GCAL licensed clinicians spend on the phone is shorter than the text conversations. What they're finding is these youth, as you see them do, right, they start a conversation and then they let it go, but then they come back to it. And so we're tracking how long a licensed clinician might be on the phone really guiding a person through a very difficult time. It's fascinating stuff. We're really starting to build an understanding how to use this. The more we can get the word out, particularly in youth audiences, about downloading that MyGCal app, couldn't be easier. If I can do it, I promise you it's easy. So we're grateful for the support and think this is a really, really important resource for the state. And just in case you're wondering, just about the scope of the Georgia Crisis and Access Line. Here in our state, on busy days, they take 1,000 calls a day. Sometimes that's people seeking help, and then you can see a little bit of the data dive there. 40% of individuals are calling for themselves, 6% calling for a family and friend, and then look at that. The majority of folks are professionals in the state who are saying, I need more help, something is in front of me that I can't handle, what are we going to do? So that we've invested in this resource, I can't tell you, and you can see that list of who's calling. This is really a vital resource. I think the most important thing that I could ask anybody to do is just continue to get the word out. And in our field offices that you saw on our color-coded map, we've got folks in every corner of the state, and if you have a meeting where people are gathering, we'd be happy to have someone come, bring those cards, the GCAL cards that you saw, or other information that shows everybody this resource is available, and we want to utilize it as best we can. Okay. So one thing that y'all asked me to talk a little bit about is the Georgia Apex program. So I'm going to give you a quick summary of all of that, and then I'm excited because my partners at the table really have a lot more to say about Apex as well. So I'm just going to give you a highlight about what Apex is, how it works, and where we're trying to go. So it's a DBHDD, it's a state-funded program, and really at the heart of it is this. It's not just about getting kids into a licensed clinical practitioner. It is really about building partnerships between schools and community mental health providers. That's what's really at the heart of it. Because the way we solve problems is really, and I heard it in your previous panel, talking about connections back to the community. How do we get practitioners that know each other? So, but the critical idea was building these partnerships, but also primarily increasing access to children and youth for needed services. How do you do that? You meet them where they are. And really the idea is, as quickly as we can and as early as we can, let's detect those kids that are struggling, either because we can see it or in some cases because they're withdrawn. But who can flag that, and how can we really quickly get them linked up to somebody who can begin a conversation and begin to help? And then we're really trying to strengthen coordination there. All right. This is our kind of fancy thing for how we show you a little bit about all the things we're trying to do in the APEX program. The main thing that I want you to know is when we think about, and y'all think about, well, I want to make sure kids could access a counselor. That's one part of it. And that for that top tier, that 3 to 5% of kids are kids who need intensive behavioral health services and supports. Ideally, that is who we are trying to target. Make sure they can access services in the most efficient way, and doing it in the school is the best way to do that. But I don't want you to bypass what's happening underneath there, because what's happening underneath there is really a big part of how we're preventing future problems. We're meeting with teachers, we're meeting with parents, we're being a resource in the school climate, in the school community, so that the counselor who's working and is seen as the APEX provider gets to know the teachers, the administrators have questions. Sometimes a teacher just has a question about a particular student. They don't know how to handle that situation. So instead of having to look online or go somewhere, you have a hallway conversation about what can we do differently. And it's really, really building partnerships between those classroom personnel and administrators and the community mental health folks. And one of the reasons this is so important, when we find a youth that has challenges and needs, often what's behind that is a family that has challenges and needs. So now you've got a linkage to the community mental health provider. And so that kid who might get some of their services actually in the school setting, right? That's the easiest way to do it. But if we find out mom, dad, grandma, someone else needs help, now we've got a connection back to that community provider. And we can really talk about how are we going to work with this family. And what the community, that community agency is also doing is connecting with an array of other providers in the community. So this is really about providing community support when folks come to us through a mental health, behavioral health door. And let me clarify one other thing. We use our language. When I say mental health, I'm thinking about what you normally think about, conditions that affect your mood or your emotions. But when I say behavioral health, in our world, that means we're talking about mental health and substance use. We're talking about addiction. So our language is important there because actually we are trying to address both through the APEX program. So people talk about it traditionally like a mental health program, but I want you to know when we say behavioral health, that means we're including substance use as well. And as you well know, that's a really important part. Okay, so we've had so far 3 phases of APEX and how it's built thus far to date. We started this as a pilot program with really a small pot of state funds that we had left over. What we knew was that the environment has changed. I can tell you, being a social worker on the ground 12 years ago, knocking on school doors with federal money, a federal grant money, and they said, we don't need that in our schools, we don't want that in our schools. Boy, has the tide turned 12 years later. We have a waiting list of schools that are dying to get the APEX program, right, and see vital needs for mental health and substance use services in their school. That's a pretty short window of time for a complete turnaround. So the opportunity is great. We started thinking maybe the time is right to really build a pilot program, and that's what we did. We got in a couple of schools, and it has spread like wildfire, right? In a good way, that people are saying, if you could be in our schools, this is really going to help us reach youth and adolescents in a different way. And really, it began to clamor all around the state for how would we get this program in our schools. You may recall then Governor Deal had the Children's Mental Health Commission, and he invested, and you all supported those investments in a lot of areas of mental health. One of the most important ones was to expand our seed money to get the Apex programs running. So that was phase 2, allowed us to expand into other schools. And then, as you well know, one of the first acts of Governor Kemp's administration was to invest another $8.4 million, again with the idea, more expansion, let's get into more schools, let's figure out how we're going to do this. So I got some good news, and then I want to make sure you know the truth of it as well. Here's a good and interesting part of this. People are surprised to hear this, but 78% of the schools where Apex is located are in fact in rural counties. So you see the number of schools, 411 is how many schools that we're in, and growing. The reason for this is intentional, because we have the ability to allocate those dollars where they're most needed. And where they're needed, as you all are well aware, in our rural communities, it's more difficult to get to your local community mental health provider or whatever it is. So it was a primary target. And as people applied to be Apex schools, we weighted more heavily those that were in rural areas so we could do exactly what you would hope, which is make sure we are a presence there. So you can see some of our other figures there. The one thing that I want you to know about the way that program works is that the money doesn't go into the school. The money goes to your local community mental health provider. In some cases, it's CSBs. We also work with some other private providers as well. The reason the money goes to the providers, and I'll try and say this in as simple language as I can, is because ultimately the Apex funds are seed money that allow the community mental health provider to maybe hire new staff, right? Get those child-serving clinicians into the school, right? Get the startup going. But ultimately, we're going to bill any clinical services that we can. That means there's revenue coming back in. This isn't totally state-funded, and it's just a pot of money that's going to continue to drain. When you deliver billable services and you can earn back the revenue, what that has allowed the community provider to do is then expand to another school. And we have a priority list by how we're going to do that. We think it's a pretty thoughtful formula because one of the things that we've learned, and in the latest wave, the 3.0, when we're thinking about which schools are we going to go to, we've got some priority criteria. Geography is one of them, but a really other important thing is the local superintendent has to be supportive. And we have to see demonstrated support by the local superintendent and principal, because if the school community is not all in, it's simply not going to work, right? So we need their buy-in, we need their commitment. We now have pretty hefty competition going on because so many people are interested, but the great thing, it's gotten school administrators talking about the importance of mental health. We also find where schools are working on their school climate, I think where they've invested in positive behavioral interventions and supports, we show that the impact of Apex is increased because you've already made a start, and now we're finding the school community is receptive. We can have more parent and family engagement, and really you're changing the dynamic in the whole school environment. And that's a really exciting thing for us. So I know you all want to talk more about that. All right, wait till you see this slide. You have this one in your packet. I won't spend too much time on it, but you did ask me what are some of the unmet needs. And so I have an hour-long presentation just on this slide. I'm going to spare you that one this morning. But I do want you to know, you all have been incredibly generous over the last really decade since we became a department. A big driver of that, candidly, has been our settlement agreement with the Department of Justice. Two important things to know about that. One, that only focused on adults. So none of the infusion of dollars that we got through the DOJ settlement agreement that's come through our budget has touched kids. That's why the Apex funds were so important. In addition, the DOJ settlement agreement really focuses very specifically on the deep crisis end of our system. And there are many, many other things that fall outside of our crisis and our deep end of the system in mental health and for people with intellectual and developmental disabilities. So you all have infused $280 million in order to move towards a transformed system, compliance with that agreement, but we are doing the right thing. But let me tell you, that didn't touch opioids. The settlement agreement was silent on the issue of addiction, And that's probably been one of the biggest, had the biggest impact on our service delivery system. In addition, I appreciate that after a couple years, and we built really some pretty impressive, we have other states coming to look at our modern behavioral health crisis centers, because these are new age, this is how it's being done. Other states are saying, how are you doing it? How are you doing the crisis line? How are you doing these behavioral health crisis centers with 24 beds, observation beds? How are you doing all of that? But a lot of you have tapped me on the shoulder and said, but maybe we should think about preventing crisis. Because if you build it, they will come, right? We are continuing to build. We have more crisis units, but that comment that you see up there, first and foremost, outpatient funding, right? The more people have access to basic outpatient clinical services, you can see a doc, you can get a diagnosis, you can have basic package of therapy, all of that, the more we can get to folks quickly and readily in that, we hope there's less emphasis on an expensive crisis system. And then certainly our hospital system, we want to be the last resort. But all of those areas, those are areas where we still have pretty significant unmet needs. I'd love to talk more about addiction. That certainly is a big driving force. I do also want to mention our forensic population. So for us, our forensic population, and you are very well aware of these folks in your community, they are folks who are engaged with the criminal justice system. They've been accused of a crime. In many cases, as you well know, it's a result of an unmanaged mental illness or sometimes intellectual and developmental disabilities that cause people to behave in ways that are not desirable in the community. That they get engaged in the local law enforcement and then sometimes in your jails, and these are folks maybe who may not have the ability to navigate some of those systems. Out of all of our hospital beds, our forensic population is the largest number and the only population that's growing in our hospital system. We are building a new 40-bed unit for forensic folks. So folks who are with us for a long time in the hospital, we're either trying to restore them to competency so they can stand trial, or they're not guilty, probably of a pretty serious crime by reason of insanity, and they're going to be with us for a long time. So this is a difficult and complex part of our hospital system, but again, it's the only area that's growing. And this interface between mental health and the criminal justice system, I know it's of deep interest to you, as it is to us. And then I'll end, because this is really, I think, going to lead to some of the next conversation, which is the workforce shortage. For DBHDD, this really impacts every area of our business, from the front line of our hospitals and the front line of our provider homes in the community. So these are 4-bedroom homes that in many cases have to be monitored and staffed 24/7. The folks who work at the front line of this work are seriously underpaid. And the workforce has extremely high turnover, and we've got gaps in every area of the state. That's true in our hospital system, because our folks who, we have cooks in the hospital, we have laundry folks in all the things you would think we have in our hospital, we do, and we don't come near comparing with other healthcare entities and otherwise. So we've got desperate vacancies. What you'll hear more about is clinicians, nurses, psychologists, psychiatrists. All of those are critical, but I don't want to forget that even at the front line of providing basic services for all 3 of those disability areas, we've got shortages in every area. All right, we are doing a couple of things about it, though, and so I want to make sure that you do know a little bit about that. I'll come back to the rural outreach, but so I mentioned our workforce. Georgia's workforce shortage mirrors what's happening all across the nation. So we are not unique in this. We do have some solutions on the way. One of them that I'm really excited about is our psychiatric residency partnership. So this is being hosted by the Gateway Community Service Board. This is unique that they became registered and able to provide a residency program so that you all know that we get creative, right? If we can't find them, we're going to make them, right? So we now have our own residency program. We are in the Gateway Community Service Board down in coastal Georgia. They cover 8 counties. We are now training 8 community psychiatrists. I have asked the folks down there to please turn on the charm. The idea is after they do a residency in our coastal community, they will make a decision to stay in Georgia and practice psychiatry in our state. That's really what we're trying to do. So that is a partnership with Mercer that we are really, really excited about. And that'll be a nationally recognized program as we try and build our own. Well, let me say a word about our rural outreach. So if you go back to our map, down in Region 4, which is really the Thomasville area that some of you are familiar with, we've got some really key staff folks down there. I want to mention one person, Jennifer Dunn, who's a licensed clinician, daughter of a farmer, and so she has been deeply engaged with the farm community and brought a lot of connections between services that are available, and particularly in the post-Hurricane Michael. We have shown up at places where nobody has ever asked mental health to be before. In so many agricultural meetings and settings, I will tell you the feedback that we got, because we're working closely with the Georgia Farm Bureau and others, is we can't march in saying we're mental health and we're here to help, right? Nobody's coming to that table. So we are in a lot of conversations about rural stress and wellness. We're working with farmer families about how can we identify when stress is really getting to another level where intervention might be needed. We are doing everything possible to communicate through channels that we wouldn't normally do within the agricultural community. And I'm really happy to tell you we're partnering with the University of Georgia School of Social Work, my alma mater. And the dean of the School of Social Work did a very important study around farmer suicide and finding out what are the root causes. She did a deep dive into, for the last 10 years, suicides among farmers in Georgia. That has yielded, it's not shocking information, but it's important information that allows us to act, right? What it tells us is that when individuals in rural areas have relationship issues, or they have health issues, or they have financial issues that become known to the community, they increase their risk significantly for self-harm. So these are the places we are trying to intervene, and we are trying to really work especially with families who see those indicators and really need to know when the crisis hits, where can they come for help. So I'm excited about all the ways in which we're trying to do outreach. It's not enough for us to sit in our offices and say they can come get the help. We've really got to be present, we've got to be accessible, and that is what our safety net is trying to do. So my last bullet on there really leads me over to the panel with my partner, Dr. Sitkoff. So we've had a really important partnership with Voices for Georgia's Children, who asked us, which is nice when partners do this, hey, we want to take a deep dive into the behavioral health workforce in Georgia. And so I'll let Erica talk a little bit about that and other things that she did, but it works best when we're working together. Nobody can solve these issues alone, so I'm happy to sit beside Erica and then some folks doing Apex live, right, like in the schools, so that we can all answer questions together, I think, about the things that you want to hear more about. So with that, yes, I come sit at the table.
Thank you. Okay.
Sorry, that's me. You're good.
All right. Good morning, everyone. Can you hear me okay?
Keep it close. Yeah. See.
How about that?
There you go.
Awesome. So I am Erica Fenner-Sitkoff, the Executive Director of Voices for Georgia's Children. Many of you know Voices. I'm here with some of my team members over there. Voices is Georgia's only comprehensive child policy and advocacy organization. And we take on all issues that impact child well-being because we know that children are not siloed by issue area. Their arm isn't, healthcare, and their leg isn't education. And we're able to uniquely connect the dots between those issues to propose solutions that can harness all of the activity in all of those areas. So that's healthcare access, early education and quality childcare, child welfare issues, juvenile justice issues. In my previous life, I am a licensed clinical psychologist. I still keep my license here in Georgia, and I did the majority of my training and almost my entire clinical career in school-based mental health programs. And I got to see firsthand the powerful impact you can have in a children's life and their ability to learn when you marry those two sectors, health and education. From there, I went on to develop the first school-based mental health program in Washington, D.C. under the education reform there with Michelle Rhee, and then went on to have the privilege to help school districts, more than 100 across the nation, with a national special education early intervention services company, tackle many of the issues that we are grappling with here, which is how to get that unique clinical expertise in all of our communities so that every child can be present and engaged in school. So with that, I am honored to be here today. Voices is here to help in any way that we can with this issue, and we're going to start with the presentation today. I did have a slide deck, but the last panel went really well, just engaging with you all, so we decided to switch it up a little bit and allow Commissioner to present, and then I'm going to talk through a handout you have in your packets, which lists some of the recommendations that we thought would be helpful for you to consider, and I'm going to talk through each of those. We tried very hard to make them tangible, concrete, and actionable, but of course, there's a lot of discussion today, and we are here at the ready to work on and look more into anything you think would find helpful. So we thought we'd ground the discussion in just a few data points to help frame what we're talking about. And we picked 3 data points that really illustrate that this issue knows no government bounds. Every single child-serving agency is grappling with this. 100,000 children last year in Georgia in grades 6 through 12 reported thinking about harming themselves. And that's from the Georgia Department of Education Student Health Survey that they administer. We know now from the Georgia Child Fatality Review that's led by the Georgia Bureau of Investigation that suicide is the second leading cause of death for children aged 10 to 17, and that attempts are on the rise. And we also know that 70% of our youth in secure detention facilities with the Department of Juvenile Justice have a diagnosable mental illness. So with all of that, you can see that every child-serving agency, in addition to DBHCD, is working to try and solve this issue. Now, those numbers are jarring, and they are scary. And the good news is, though, there's good news in that, is that Georgia has done a great deal, and you heard some from our previous panel and from Commissioner Fitzgerald, to invest and start to really tackle this issue. And some of the recommendations I'm going to talk through are ways that we think we could consider trying to continue to move that investment forward. So this is a complex issue. I'm really thankful, one, to be up here with my colleagues, but also to go after the first panel because they helped lay the foundation for a lot of what I'm going to talk about. I mean, they really teed up some of these recommendations that we have. It's a complex problem. So we thought the easiest way to go about describing it was to tell a story about the 4 Ps. People, places, providers, and payers. And that's how I'm going to walk through the discussion today. So we start with people, and that's children birth through high school. Now we have a study committee coming up, the Infant and Toddler Social Emotional Development Committee. So for the sake of this presentation, I'm going to focus on kindergarten through high school. Places, that's where any child can access these services. As we heard earlier this morning, that schools, including after-school programs, it includes pediatricians' offices, clinics, our county safety nets. Programs, what we mean by programs are our school-based mental health programs like Project Apex, but it also means all of the training that happens for those clinicians as well as those people that are working with children every day, and includes the practitioners themselves. And lastly, payers, the main 3, private, public, and charitable. People, our kids. We know that to meet the needs, truly meet the needs of a 5-year-old versus a 10-year-old who's been in 5 different foster care placements versus a 15-year-old who has an eating disorder, that level of expertise that's needed from a clinician to really effectively meet those needs can look very different. It's not necessarily a one-size-fits-all. And we also know that how they get access to those services greatly depends on who's paying for them. who their insurance provider is, whether it's Medicaid or state health benefits plan or private insurer. Right now in Georgia, by the last estimates, we have about 200,000 children in Georgia who don't have health insurance coverage, the majority of which are actually eligible for Medicaid or Peach Care. So the first recommendation we'd love for you to consider is eliminating the barriers to enrollment by encouraging the Department of Health and Human Services to keep the Gateway system on, which is the online enrollment system where parents can go in and enroll their children in Medicaid and Peach Care, available 24 hours, 7 days a week. We learned over the past year that that system is only on from 8 a.m. to 4 p.m. And for working parents, it makes it very challenging to go online and fill out an application that can take multiple hours. And unfortunately, if you start it outside of that window of time, it doesn't save, and you have to start all over again. So that would be something we'd love some consideration. The second has to do with training child-serving adults. That includes not just our mental health providers, but all those that work with children. It includes our teachers. It includes those working in after-school programs. It includes bus drivers, anybody on how to address the experiences of trauma that children and families experience. And third, that we ask, as I say this next to Commissioner Fitzgerald, DBHCD through the Interagency Directors Team. The Interagency Directors Team, IDT, is an incredible group of leaders within all the state agencies that work on behavioral health, as well as consumer organizations, as well as provider organizations. They all come together and report up to Behavioral Health Coordinating Council. We ask that that body coordinate and align all of the different training that happens across our state. So we've got Department of Education that does this training, DBHDD, Department of Family, Division of Family and Children's Services, and it would be really powerful, and you heard some of this earlier, if we could harness and coordinate all those different trainings that are happening to really maximize reaching much more of rural Georgia. All right, places. So removing the barriers to healthcare and transportation will be a game changer, we know. And we believe a key way to doing that, and you heard some of that this morning, is through those partnerships, and Commissioner touched on this as well, partnerships with local community providers that have this expertise in healthcare with schools. Right now, Voices is doing, in addition to the workforce analysis the Commissioner mentioned, an in-depth review of several school-based telehealth programs, as well as school-based mental health programs where they have partnerships through Project Apex, as well as some private partnerships to get a better understanding, and we look forward to sharing that with you when it's available this winter and this coming spring. We support the increasing of federally qualified health centers' capacity to allow existing school-based health centers, comprehensive school-based health center partnerships, to augment their services with behavioral health services, as well as increasing FQHC's capacity to create new comprehensive school-based health services. One reason, one benefit to doing that, in addition to standalone partnerships with mental health providers, is you're much better able to identify what is truly a physical health system but may look like a mental health problem. So a child that's having aggressive behavior in the classroom and is really struggling with their behavior could in fact be that they can't see the board and they're having trouble expressing that. Or their tonsils are inflamed and they're in a lot of pain and it's coming out as acting out and they just don't have the understanding to express that's what's going on. And looking at health holistically in that way, from a physical and behavioral health, mental health perspective, allows us to really accurately identify what's going on with kids and families. And that happens a lot in partnerships where you see a Project Apex provider partnering with an FQHC to provide that holistic care. So it can be done very successfully in partnership. So of course, we strongly support the continuation of Project Apex and the incredible work that it has had, and to take that foundation and think about that holistically as part of the panel this morning talk about. The other thing, telehealth came up quite a bit this morning, and there's a great deal of opportunity in our state to maximize that. And we believe a study committee on telehealth would be beneficial. We see it working very well in places, and you heard some of that today. We know some communities are experiencing challenges, as Madam Chair Cooper expressed. A study committee would help us identify and lift up those practices that are working well and target where we could, better maximize and have more opportunity. Programs and providers. So we've put money into this, which is great. Don't get me wrong. The funding has been amazing. But we don't know where all of the mental health practitioners are in our state. We don't collect that data. We don't know who they are, what specific geographic region they serve, whether they serve children versus adults, whether they have any specialties, how far they are away from retiring. So our first recommendation would be for the state to collect data on our mental health workforce in a similar way that we collect data right now with physicians through the Georgia Board for Healthcare Workforce. It would be incredibly powerful for us to have that information and develop solutions and targeted strategies based on that data, and would give us that insight. We also support and would love the consideration to create state-supported residency slots for pediatric specialties. So when we speak about primary care residency slots expansions or psychiatry residency slots expansions, it's important to note whether that's pediatric, because there is a difference. There's additional fellowship training that psychiatrists have to undergo to be able to see children and adolescents. And we encourage thinking about those residency slots with pediatric specialties in mind. Fourth, incentivize mental health graduate programs to develop curricula that better meet the needs of rural Georgia. And what we mean by that is core foundational curricula as well as training opportunities. So for example, when I was in graduate school, all the years that I was in school, I was in clinical practices, practicing that under comprehensive supervision. The same way works for all of the training programs in Georgia. How can we think about getting those training sites out to more of rural Georgia and a more formalized partnership there with those community providers to do that? We talked with some mental health providers across the state, including Project Apex providers, and they are struggling keeping the workforce in their programs and in schools because recent graduates are coming into those settings ill-equipped to the level of care that they need to respond to. Kids disclosing thoughts of suicide or attempts of suicide, disclosures of abuse, domestic violence for the first time. They're telling this to someone, and those providers did not have that training in school. One way that we could start to do that or think about that is to develop a workforce pipeline pilot. And there are several programs that are doing that right now we could look at. Georgia Hope, headquartered in Dalton, has a pipeline, as well as Aspire in Dougherty County. Also to explore how technical colleges can certify registered behavior technicians. That's a paraprofessional position that can work in schools to help meet that need. Okay, I am gonna quickly move along because I am running out of time. I'm gonna highlight a few other things. We heard a lot from the first panel about providers in rural Georgia being isolated and not having that network of peers that they can collaborate with. We think it could be helpful because Carl Vinson Institute has been working on this workforce issue to look at how we could bring the ECHO model to Georgia, which would be a support model where providers in rural Georgia that has a student that has experienced intense trauma and they don't have that ability to serve those needs. Commissioner talked about they're calling the crisis line right now to get that support, but there could be a network that we could do and put in place for the university system. Two quick things I'm gonna note before I wrap up, if that's okay. I know I'm getting in trouble. Okay, in payers.
Yeah, I mean, you know.
In payers, one quick note about payers, and I'll say this, there is still a great deal of confusion out there of what is covered and reimbursable and what isn't. So and if we could compare what service are reimbursable for how long and who can, and do that analysis and do that comparison and have a real clear understanding about where we can use some federal grants like the Family First Prevention Services Act, Every Student Succeeds Act. It could go a long way. Final recommendation, and that's this in your packets. Create a school-based health hub. It would be a one-stop shop where rural communities, any community, but particular rural communities, can go to get the support they need to create these programs in their communities. One stop. The previous panel talked about this, that it's really hard to find that information, how to develop those partnerships. One place where they could go to figure out what training schools need or professionals need, how to develop those partnerships with community providers. One place we could look, South Carolina has one. It's located at the University of South Carolina. There's different funding streams to make that happen. Thank you very much.
I'll make mine really quick.
No,
'Cause I
you
think-
are the folks on the ground.
Yes.
And
So
we
I'm
certainly want to hear from you.
Okay, thank you. I'm Whitney Carnes. I'm the school social worker here in Pickens County. I'm starting my 7th year here. I've been a school social worker for about 17 years, well, starting 17 years. And we have the APEX program. We're starting our 3rd year. Superintendent Wilson is super supportive of mental health needs being met in school. And that makes my job a lot easier, having his support. We added Kayla, another social worker this year. We added a trauma counselor in our schools last year, and that's in addition to the APEX grant. And we're expanding it from 3 of our schools to all of 6 of our schools this year. One of the issues, and I think they were kind of alluding to this, is we don't have enough LPCs, licensed clinical social workers, in these rural areas to serve. I know Melanie Dallas is here from Highland Rivers. They've posted a job for an LPC to add additional clinical workers in our schools, and no one's taking these jobs. If we had some sort of an incentive program, much like DFACS did years ago, to add caseworkers with scholarships for school to pay for their schooling, and then they're going to commit to the workforce for a few years. I think that would be nice to do some incentives for LPCs and licensed clinical social workers so we can have more positions in rural areas. When I'm at home at night and I get word of something that happened in our community, I have to think, how is this going to affect school tomorrow? Sorry, I'm nervous. Sorry. But, how does this affect, if a child dies at one of our schools, we rally all the counselors, let's all go to that school. But they have siblings in other schools, it impacts the community, and we're the ones that have to handle that each day. If there's a tornado, if there's a fire, we are the ones that are firsthand to see those kids the next day. And looking at our state ratios for school counselors, school social workers, the funding for that, I think that's worth taking a look at, because when we have one counselor per 450 students, one social worker per, I think it's 2,000 students, that just, in the big scheme of things, we Band-Aid so much. And we can really do a lot of prevention if we can meet these students when the crisis happens and try to connect them and be the resource for them before it turns into substance abuse and additional criminal behavior and things as they grow older. So that's kind of where I see you guys being able to support us on the grounds in the school system. And thanks for the opportunity.
Hello, I'm Kayla Kinzer. I am new to school social work, but I'm certainly not new
Close.
to, sorry, loud enough? I usually don't get that I'm too quiet. So I'm certainly not new to the profession. I worked in state mental health facilities all over the state when I started my career and worked with kids with extreme emotional and behavioral disturbances. And then I took a hiatus and worked in healthcare and focused on veterans at end of life and access to rural community resources. So I have come back to work with children because I feel like if we can get to a place where we prevent a lot of the things that we see in adolescence and early adulthood in elementary school age children, then we can prevent a lot of what's going on in criminal justice and mental health across the state. So Dr. Wilson has allowed me the opportunity to work this year on programs that will increase our insight into what's going on earlier, because we do have lots of elementary school age children who are suicidal and who have sometimes homicidal ideations and self-harm behaviors and lots of mental health issues that are not being addressed at home certainly or in the community. So we're going to work on that. We do have a little bit of insight across this panel, so I will quit talking and allow you to ask questions if you have any.
Sure, I bet we do. Let's start off, Morley Rogers.
Well, no, I just, you guys are the ones on the ground, and one of the things you were talking about, looking at it from the perspective of, and I live in a small community also, looking at it from the perspective of when something happens, how does this impact the children the next day, the school aspect and everything else? I would think that that is seriously compounded by social media also.
Oh, absolutely. I mean,
Can you kind of address that? And then also, Kayla, this may play into what you're saying, looking at different programs or whatever. Is there a possibility? I'm a huge fan of GCAP. I mean, is there a possibility of some sort of local, I don't know if you do it through Facebook, I don't know what you do. I mean, you have your own Facebook page where it's constantly updated to maybe the parents can go to and talk with their kids about different things or whatever. I don't know. But what I'm saying is there a possibility of reversing the negativity of the social media and maybe getting ahead of it on the offense?
absolutely. I mean, that's usually when I find out something's happened, you know, through social media. And we do try to reach out. I hope I'm answering your questions through social media. I know we put out a thing in our newsletter. These are your school counselors to the parents. We try to get word out about the APEX program, our trauma counselor. I'm not sure I'm answering this question right. But
I do think one of the things that we are trying to implement, not just social media wise, but our communities, like in elementary schools, middle schools, communities of kindness and supportive behaviors, so that we can talk to them what appropriate communication looks like, how we're supposed to talk to our peers versus how we actually do sometimes talk to our peers. We're doing a lot of interpersonal communication support with guidance counselors and that kind of stuff, because sometimes kids come to us and they think it's really appropriate to use negative language, not only to talk about themselves, but their peers and their teachers and administration. So it's really just a lot of education and modeling for them what it looks like to have appropriate communication.
So you're probably, I think maybe what you're saying is, besides the mental health aspect, you're having to bring soft skills into it also.
yeah, that's one thing. When I emailed some of my peers in other counties and school counselors, just the coping skills with daily, because a lot of the kids are not, you know, they're communicating through text messages and all these apps, and they're not dealing with real life problems a lot of times. So they're really lacking basic coping skills and social skills, and we see that every day at school.
If I could add one thing, because I didn't even mention, part of DBHTD's work is in prevention. And almost all of the prevention dollars that we get are federal dollars. So we have to use evidence-based programs, but there are some really good ones out there. Sources of Strength is a good example of one, because I think you've hit a really important point. It's about how do you get the conversation going before there's a crisis so people know who to turn to. One of the greatest findings in all of this has been when you find the peer leaders, kids will go to other kids oftentimes before they go anywhere else. So it's really empowering kids to know how to help and role model for one another, and then how to help those kids, not that doesn't become a burden, right, for a school leader or a kid who hears things, that they then have the tools for what would they do, how do they reach, and really get kids talking to other kids in ways that are positive. And that really has been shown to be one of the most effective tools to really change the conversation for the adolescent population.
I want to go back to GCAL for a minute, because sometimes I think when we're having this conversation, it is so overwhelming. I mean, it's sort of like, you know, what can I do? You know, I mean, it's almost like the starfish thing, like the little kid walking on the beach throwing starfishes in, you know, and the old man comes along and says, there's millions of these things, you know. You think throwing that one in is going to make a difference? Well, it made a difference to him, you know. But the actuality is, it is an overwhelming problem. But when GCAL was first launched back, February, something like that, I know that I did a video. I do legislative updates and did a video and included as part of the video, and I was absolutely amazed. There were probably 10 different people that came up to me afterwards and said, hey, I saw that about that thing, tell me about it and how do I get it or whatever. So I think that's a lesson that we can all walk away from, is that we can all do a little something or another, and maybe it adds up.
Well, I thank you for mentioning it. Every call matters, that these are licensed clinicians. I would invite any of you, we've taken a couple of tours to the GCAL, and it's literally, it's a call center, it's a pit room, like you might think it is, with licensed clinicians with headphones, but a thing that is jarring when you go in there is, because that's where we deploy mobile crisis, we have an active, visible electronic board of everyone that is in crisis in the state. I mean, you have to sign a waiver if you come in, because and we can see on an electronic board, this is pretty sophisticated. It's gotten more sophisticated over the years of where are they? Are they stuck in an emergency department? Are they being transported to one of our hospitals? Are they in waiting? Who needs to be doing something extra here? But it's literally the advances we've made in being able to manage this. But I am shocked. When I go around the state, almost any audience I speak to, I start with, have you heard of GCAL? Raise your hand if you know what GCAL is, and it's the minority. So we will arm you with the cards, and the MyGCAL app any way we can, and be at your local forums to just make people aware of this important resource. So I thank you for just raising it. They don't have marketing money, right? So they know by virtue of people saying it and the word getting around. We'd love to invest in getting the word around in more formal ways, because it's a unique and critical resource. They are saving lives. Those 1,000 calls a day, that's our citizens in need of help.
Chairman Taylor.
Thank you, Mr. Chairman. Just a quick question, I guess, and none of these questions are simply answered. It seems like there's an increase in our needs for mental health, and we're talking about preventing individual episodes. Are we looking at the cause for the increase? And again, I had been on the DFACS board many years ago, and I have been able, I wasn't intervening in the middle of crisis that kids had, but it would come through DFACS often. I think some of it is deterioration of families. I think some of it is school issues. I know one of my schools had a kid that was in, honestly, he was in preschool, and he picked up a desk and threw it at a teacher. He was the baby of a mother that had been on crack. These are things that are social issues. I know we can help one kid at a time, but are we reaching out anyway to do something about the social issue, whether it be family? As I said on DFACS, sometimes we have put children back in a situation they should not have been in. And I think that we've got to prevent each episode, but we've got to look at it at the big picture too. Why is this happening, and how can we look at that? I get it. We got to fix what's going on right now. And is there some big plan out there to look at this? Thank you.
So let me offer, thank you for the question. It's really important. Let me offer one answer, and I mentioned the department's prevention efforts, and really it is about being visible, being available, teaching kids how to talk about mental health, your emotions, and coping skills that have been mentioned here. I do want to say one of the other things that the department takes seriously is our responsibility to look at an aggregate. What's the data telling us about what's happening? It is absolute. There is increased demand across every age category, from young to the oldest adults who really also have increasing, especially mental health issues. We do know the rise in addiction is also a big driver of that need. The opioid crisis has certainly brought that to bear, but I try and say wherever I can, alcohol is still the #1 addiction issue in the state. So even as we address the opioid use disorder, addiction is the core problem. I want to mention one other thing, though. For the first time, our department, we have an office of sort of statistical experts who are doing exactly what you would hope we do, which is looking at the aggregate data as best we can. Now remember, we're looking at the people we serve are largely uninsured in the Medicaid population, so we're a small slice of the needs in the state, but you can get a look at it, and for the first time, we did a really statistical analysis of the suicides in Georgia. This is available on our website, and it is really analysis of when we look into each of these records of suicides that occurred, of people who had touched our service delivery system, how can we walk backward and know what's happening sooner? How do we need to change the way we deliver services? So I think, and the report is really thoughtful, it's scientifically valid, but most importantly, it gives us some training and some direction about where do we need to impact, and it is right at the moment when somebody says, I think I need help, I'm thinking about harming myself, and that's the point at which we really have to do a more aggressive intervention, and really there are a lot of validated tools by ways to do this, so we've got lots more information, and finally, people are willing to talk about it now in a way that they didn't used to be. Suicide rates have increased in every state in the nation except for one, and across every age category. Something really serious is going on, and we've got to keep looking at it.
Chairman Powell.
This is directed towards Judy. Dealing with GCAL and dealing with the crisis intervention centers, I think that initially after we entered into the agreement with the federal government, and so we had to go to this different model, a lot of it was that we had gaps in coverage up until we got it up and running, and a large part of it was that we had lack of education as far as understanding what to do. But the complaints I got from my probate judge, my state court judge, and my sheriff were that basically we had taken these people out of the mental hospitals and we'd either put them in jail or put them on the streets. And I still get those complaints, but by and large, the fact that we've expanded the crisis intervention centers has helped, because they just did not have the capacity to begin with. But my state court judge is still giving me an earful from time to time, and I want to read you what he said. I told him that I was in a conference with you, and I said, what do you want me to tell her? And this is what he said. Tell her much of what they are doing is working, but there is a terrible failure with the chronically mentally ill who cannot be served in the community. For example, I have spent the last 2 to 3 weeks dealing with someone who is on intensive supervision, the ACT team. They can't effectively serve her and make sure she's on meds because they can't find her. She has been in and out of jail and the crisis hospital, but they will not place her in long-term care. I even called the state medical director, and they still said she did not meet the criteria for the state hospital. I fear that she's going to approach the wrong person and get killed.
That's a painful story, and I don't doubt any of it. And I think it's not unique, it's troubling, it's the challenge that we have. There are people with chronic needs that really can only be served over a long period of time within the hospital system. So I want you to be clear, we believe that. The crisis service delivery system that we have built and we are building can meet a number of needs, but it can't meet all of the needs. We have more crisis beds than we had hospital beds at one time, but the practical issue remains that there are still a core group of chronic individuals for whom hospital care is the correct place to be. Now, here's the reality. Our hospitals are full. We have about 1,000 hospital beds, approximately, and there are 3 populations in the hospitals. There are individuals with intellectual and developmental disabilities. That's about 150 individuals who still remain in our hospital. When we signed the settlement agreement with the Department of Justice, we closed the front door. If somebody has a primary diagnosis of an intellectual or developmental disability, they cannot come into our hospital. We signed the agreement and said that. So all of the remaining folks, we are working slowly and carefully towards transitioning them to the community. The rest of the beds in the hospitals, across the 5 hospitals, are either adult mental health or they are forensic patients. Children cannot come into our hospitals. That also ended before the settlement agreement. So what that leaves us with is a limited number of beds, which are constantly full.
So what do we do?
Yeah, what do? We're really going to have to keep talking about this. One of the other things I want to make you aware of, when we closed, part of what you all have supported when we signed the initial agreement, we as a state agreed to build the community crisis services. But another thing you're going to start hearing about is another thing you allocated in our budget was the ability to buy 35 private hospital beds a day. Right? Acknowledging you're going to close, it's going to take you a while to build up the community. People are still going to need hospital care. So when the settlement agreement started in 2010, we had the ability to buy 35 beds a day. We currently buy about 100. And y'all never gave us any more money than what we got for that because you don't know, and we just keep buying the beds because the need is dramatic and it's present. We need your help. And we need to keep talking about what does this look like. Now, one of the things you all did allocate, because part of the question is, why are so many people in crisis? Why aren't we getting them to them earlier? And I really have to say the complexity of addiction in our communities has really, really multiplied the problem. And also, adults, young adults in particular, with somewhere on the autism spectrum, who did not have that early intervention. I see my school partners nodding. Now we have the ability to identify that quicker and begin interventions that really change the trajectory. About 15 years ago, we didn't have that. I hear from every community about young adults somewhere on the spectrum, and the specific diagnosis doesn't matter as much as this individual has behavior needs that cannot be met in your mental health clinical services. That's correct. It's a really big and growing need in our communities. So,
as an aside, he said that the next time he got a 2 a.m. call, he was going to call me.
That's fair, and you can call me. And how you know you can call me is because I go to the sheriff. I meet with the Sheriff's Association, and I go with my tomato-proof suit, and I give them my cell phone number and just say, if and when you have a crisis and you have worked through my team and you feel like you are stuck, because there are a handful of individuals for whom our system cannot solve right now. There is a growing and continuing need, and I really just have to underscore, addiction is a very complex part of this that we are not prepared for. We don't have the workforce to address that.
Chairman England's next.
Well, not so much a question, more of a comment or several comments. As we deal with mental health issues, you know, for years we've had a system of hospitals set up to deal with physical ailments. And so we understand how to treat cancer, we understand how to treat kidney stones, we understand how to set a broken leg, we understand how to do a lot of those things. We're getting much better at those every day. The thing with mental health and issues with mental health is every case is unique and every case is different. In a lot of ways, it's kind of like Alzheimer's. We all know that Alzheimer's, there are no 2 patients that are identical, and that's much the same way that it is within mental health. And I want to first give a shout out to Chair Lady Dempsey for the work and years of work that she's done on these issues, even before she became a House member, but for her work over the last many years as the Chair Lady of the subcommittee that handles the Commissioner's funding and a lot of this work that we've been doing. But I want you to think about something, and this is a statistic that I've heard repeated many times, and Judy may say that it's not right, but it's one I've heard many times, is when you're sitting in a crowd of people, look to your right, look to your left, and of the three people sitting there, 2 of those individuals on any given day have a mental health issue. I'm feeling pretty good today myself. But I say that to keep from actually breaking down and squalling, because this is something that's been incredibly important to me and the folks that are in this field, and in particular Judy and her team and the ladies, all the ladies sitting at the table this morning, have servants' hearts, because in their role, a good day, the best day that they have, is a day that they don't get a phone call saying something bad has happened. And, you know, I sit back sometimes and think about agency heads and the jobs that they have, and I think about, really about 3 positions in state government that I just pray to the Lord I never get asked to fill. And that one of them is Judy's job, one of them is Tom Rawlings at DFACS, and the other one is Frank Berry at DCH, because those are 3 thankless jobs. And Judy's, in a lot of ways, may be the toughest of all because of the Department of Justice settlement and the seeming to never be able to fully satisfy those that are looking over our shoulders and those that are giving them prescriptive instructions that are flawed from the beginning. And there's no way to ever win. You know, we were really encouraged at the end of last year and the first of this year that we may roll out from under that settlement to be able to truly do what we need to do for the folks that are here in the state. As you all know, many times we get federal funding for whatever. Medicaid is a prime example, and they're very prescriptive on how you spend those dollars. Well, somewhat the same here, except there's not a whole lot of funding that comes with it, but they're very prescriptive on what we're to do. And then when we do what they tell us to do, they change or they come back and get on to us because what they told us to do didn't work, and it was their recipe. And I've been on the phone many hours with Judy and with Frank and Judy before Frank moved over to DCH, when we sat there and cried with each other, and when we've sat there and sometimes talked like sailors because we were so mad as well. But not so much Judy, maybe me and Frank maybe. But you know, I just want to say this today, how much I appreciate Commissioner Fitzgerald and her team at DBHDD, and all of y'all that are on the front lines, especially in the schools, dealing with these issues day in and day out. Our folks at our hospitals that have these people that show up in their ERs, that there are no beds. There's nowhere to send them to a community service board or any other provider, and they're having to keep them in an ER for many days on end within an arm's reach of someone. Someone, in these cases, an individual laying in an ER, in the time that they're in the ER, have to be within an arm's reach of someone that can keep them from doing something to harm themselves. And in small rural hospitals, this is a big issue because they may only have a handful of staff, but if one person is having to stand there for 10 days, 15 days, 25 days, an arm's length away from one of these individuals, it means that other people are coming in that they can't help during that period of time. And I know that Judy and her team have been working on some kind of unusual cases over the last few days, one in particular, of where there's just nothing to do for some of these individuals. They don't fall into any category because, again, what I relate back to what I said a minute ago, each case is individual and unique and different. But all that said, my heart is out to you. Thank you for what you do because y'all truly have servants' hearts. And I couldn't do your job. Thank you.
Mr. Chairman, thank you so much. I want to make a point about the settlement agreement with the Department of Justice because you have said, well, all of the frustrations that we have. I've been proud to sit across the table and tell them there is no other state where the leadership of that state has been as committed and has demonstrated their commitment both financially, emotionally, and by listening. And by, not throwing rocks, but saying, how are we going to solve that? I've been really proud to represent what you all have helped support. I'm here to tell you we need to have a different fight, though, because we are doing the right work. And whatever it's going to take legally, we are going to make sure we do it in a way that works for Georgia. I feel feisty about fighting that fight ahead. So I wanted you to know that. But thank you. And, of course, thanks, Chair Dempsey, for your support as well.
Well, we're just going to take Chairman England's nod and call on the fine Chairman Dempsey. Let her say a word, please.
Well, thank you. It has been a privilege to be here with y'all. You have just glimpsed into a window that is so powerful. Every single word that's been spoken here by all four of you and by the panel before, it's our profound challenge. It really is. And it brings back, I would say that there's probably not a person in this room who hadn't called me, even in very recent days, with a challenge in your own community about a person. And that's what we've got to keep the focus on, the person. It's not mental health. It's a person struggling with the crisis of mental health. It's not addiction. It's a person who has an addiction. It's a person in recovery, if we do it right. It's a child whose pain is immeasurable. I mean, there's no way to know the trauma that each and every child has today and faces quite accidentally and sometimes on purpose. Some of them have insurance. Some don't. As a state, we're really charged to work with those who fall in that gap. But in our communities, it's often also someone on the street who actually has the resources, has a family, has a way to have that help. Maybe doesn't want it, maybe has tried and frustrated, maybe is running away from help in dealing what they feel is their reality. So when the frustrations come from hospitals and sheriffs and judges and everyone else, just remember that the tools we have really to address this are to get in on the front. The earliest front, the first breath of life, the time before a child is born, even in many cases, with that family, with that mother, with crisis that is hard to see and hard to measure. So I thank y'all. What a great group y'all are. This is my first visit. You may see me more because y'all, the work you're doing, I knew it was important, but now I've seen how very important it is. So thank you, Chairman, thank you. And y'all, we need to fight for these people that sit at this table and get behind them. I don't know anybody else who could do it. I really don't, so thank you.
Well, thank you, Madam Chairman, very much for all your passion. I've got a question, of course, for Whitney and Caleb, real quick. So how many young people do you guys see in a week? Give us kind of, I'm just thinking it'd be good for us to kind of, what are you looking at, dealing with, and how many?
Okay. I mean, every day's different, but last year we had 158 students that were having either self-harm or suicide ideation, where we had to call the parent in to meet with us and refer them to additional resources or for a suicide assessment. And that was up from 107 from the year before. We probably see, I don't know, probably a case, about 5 a week. I mean, we have 6 schools. We have 4,300 students approximately. So, I mean, that one is too many. But we had a 3rd grader come to us out to one of our elementary schools coming from another district, and the school counselor from the other county called and said this child, 3rd grader, has been hospitalized and has homicidal, suicidal behaviors. And, just want to give you a heads up, he's enrolling in your school system tomorrow. So we make, you know, a few DFACS referrals a week. We deal with suicide ideation, I mean, probably at one of our schools almost daily. Sometimes multiple, but the school counselors are seeing probably at least one student almost daily that has thought or considered suicide. And it's, I mean, like I said, even one a week or one a year is too many. So, but a lot of it, I will go back and say, a lot of it is substance abuse at home or a parent's mental illness that was never addressed.
So my schools are the alternative school, the psychoeducational school, and the elementary schools. And so far, Whitney has helped me tremendously this school year with those. I get calls pretty much every day, not always suicidal or homicidal ideations, but I certainly get calls every day because there's some sort of a catastrophe or crisis that we have to deal with. I know Whitney does as well in those schools because something is going on. We consistently have neglect issues that are happening, which is very hard to prove, as we all know. So realistically, we probably have at least 5 students a day that we're constantly doing some sort of planning for, some sort of intervention.
Just a comment for the commissioner. The psychiatric residency partnership program, I think you mentioned there was one in coastal Georgia. I just wanted to put it on your radar. There's also one in Colquitt County with Colquitt Regional Medical Center and Turning Point, and they got a pretty big, nice grant to do that. So just want to make sure you knew that and put it on your radar. So we look forward to what they're going to do there.
Excellent. Yes, thank you. And thank you for mentioning it. And there's another one emerging in Columbus. So there's a lot of momentum of people saying, we've got, the workforce isn't there, we're going to have to invest. But it's true all across the board. So thank you. Thanks for mentioning it.
Oh, that's right. Sorry, guys. Can't say a word, but you did a report on workforce. We didn't talk about it. I hope you would get that to us so we could learn from that. Let's give them a hand. Thank you. Census, Rusty Haygood and Julie Walker, and Julie's going to stay up there and do hers together. And
Good morning, and thank you for the opportunity to be here. I promise that I will be as quick and as brief as possible during this presentation, but I do want to give you an update of what we have been doing within the state of Georgia to get ready for Census 2020. About 2 years ago, Governor Deal issued an executive order where myself and Anna Miller, who works with the Office of Planning and Budget, were named as co-chairs of the State Complete Count Committee. This committee was comprised of about 45 individuals from around the state. We started by thinking collectively and developing a game plan over the last few months. We've kind of ramped up the meetings that this group has had. We have a follow-up committee meeting next week as well. But what we're trying to do is work on the message that gets out throughout the state of Georgia. And what we're trying to do is make sure that message is A, consistent, and B, is compelling so that it encourages people to participate in Census 2020. I'm not going to stand up here and give you a history lesson, but I want to make sure that the points that I make today are the points that we're trying to make throughout the state. Make sure we've got those reasons why people should be participating in the census, completing it, and encouraging their friends to do the same. There have been a number of partnerships that have been formed through this, and I am grateful for those. And I'm also grateful for the funding that was allocated by the General Assembly, signed, approved by the governor for census efforts. We are going to be putting that to good use in the days ahead. when we get down to nuts and bolts of it, why does it impact someone's life? It impacts them for two reasons, and those two reasons would be power and money. I say power because power boils down to political representation. We all know that it's a zero-sum game in Congress. We've got 435 members of the House of Representatives. When a state gains a seat, a state loses a seat. So as the state grows in population, as that count increases, we have the opportunity to gain more congressional seats. You may be interested in the census because we have reapportionment at the state level. We've got House and Senate districts that are carved up, and the census is going to be the foundational element for that as well. When you talk to people throughout the state, throughout communities, and they understand that county commission districts, city council districts, board of education districts can all be carved up based on census data, it starts to resonate with them, and it starts to make an impact on their daily lives. They can see where the census does touch them on a daily basis. I've got a couple of maps here. If we go back to the 1990 census, excuse me, that's 2000 census, we had increased from 11 congressional seats to 13 as a result of Census 2000. We go 10 years later, we added another seat. We go from 13 to 14. And you can see other states are losing when it comes to political representation. Georgia's been very fortunate. We've gained 4 congressional seats over the last 3 censuses. So that really makes an impact in our how much influence we have in Washington. Let's move over to the money side of things, and I'm going to do a little audience participation here for just a moment if I can. Will everyone raise their hand, please, and leave it up?
If you would.
Why does it matter to your community? Leave your hands up. If you know anyone that receives Medicaid, take your hand down. Everybody else, leave it up. So those that took it down know someone that receives Medicaid. How about Medicare Part B? Receives a housing choice voucher, Section 8 voucher. We've got every hand almost down. The school lunch program. Anybody, do you know anybody that participates in the school lunch program? WIC, SNAP, Head Start. Now we've got everybody. George Washington University did a study, and within this study, they identified 55 federal programs that are formula-driven, and the census data is a portion of the formula. These are just 7 of the 55. It's not necessary for us to go through all 55, but you know someone who is impacted by these federal funds that come back to the state to provide services for folks. Now, the next part is a little bit confusing to some folks. I want to make sure we dispel any rumors. In FY16, according to this George Washington University study, $23.8 billion came back to the state. Roughly 10.5 million people at the time. That equates to $2,300 per person per year coming back to the state. What that does not mean is every individual that completes the census is going to get a check for $2,300. We've heard that misconception. That's not true. It does not mean there are going to be $2,300 coming back to the state coffers for every person that gets counted, nor does it mean, and I had quite a lengthy conversation with a county commissioner who was convinced that $2,300 was coming back to that county for every person that was counted. That is not the case. What it means is $2,300 of services on average come back to the state to provide these services. Where these services are provided, that's probably going to mean that the state or the local government is not going to have to contribute that full amount. So that's why it is important and impactful within the state. $2,300 per person per year on average. Now we're talking rural here, so why does it matter to your community? In that FY16 report, Georgia received more rural assistance than any other state in the nation. $1.4 billion in FY16. $47 million went to rural business and industry, $45 million to rural water and sewer distribution systems. Truly impactful within the state of Georgia, specifically in rural parts of the state. Census 2020 is going to have challenges, plain and simple. We know that, and what we're trying to do as a state complete count committee is identify what these challenges are and develop remedies to them as we go along. Some of these challenges, knowledge gaps. I mentioned talking to the county commissioner who did not quite understand. But I'll give you a few stats that come from census survey data. They've gone out, they've done some field testing, they asked some questions, and all of the stats that I give you in the coming list are going to be directly from that. 2 out of 3 said they were likely to participate in the census, which is okay. Not great, but it's okay. 53% believe that the census data is used to locate people living in the United States without documentation, which is not true. 45%, only 45% knew that census data helps determine how much money communities receive in federal funds. We've got to make sure that folks know that there is a true impact for that being done. Apathy. 41% believe that their participation mattered very little. So we do know that there is apathy out there. Concerns about confidentiality and privacy is a big thing. And this goes twofold. We'll get into the second one in just a moment. But the first, people want to make sure that their information is protected. I will give you an illustration very briefly. In 1950, the Truman administration was going to have the White House renovated. They had the Secret Service go to the Census Bureau and say, hey, we need the information about the people that are going to live in this, that are living in this neighborhood, because that's where we're going to move the president. The Census Bureau thanked the Secret Service for coming and refused to provide the data. After a few challenges, it was determined that no, the Census Bureau does not and cannot release that data due to Title 13 provisions. If the Secret Service can't get this to protect the president, chances are it's not going to be released for any other reason. That's the law. That's quite simply what folks need to be aware of. This data does not get released on the individual level until 72 years have passed. So in the year 2092, whatever comes out of Census 2020 is released on an individual basis, just like in 3 years we're going to release the 1950 data. I want to skip down and hit on online response. This is a new element that has never been in census before. The online response is going to be where the Census Bureau is trying to drive individuals. 80% of the population will get a postcard in the mail that says, go online and complete the census at this URL. 20% of the population will get the traditional letter and a form attached to it. This is going to be very different than what we've experienced in the past, because everyone did get the form previously. There will be a way that everyone gets the form before all of the census mailings occur. I'll talk about that in a moment. But 80% of the folks are going to be driven online. Now, what demographic do you think is the most likely to go online and complete the census according to the Census Bureau's field testing? We're going with millennials. Seniors were the most likely to go online and complete the census.
No kidding.
Why? Because they've always done it. They realize the value of the census. It's not something new to them to complete the census. Millennials were the least likely to do it. Could that be because they've never done it before? Could it be because they don't care? Could it be because they don't understand the ramifications for not participating? So, quite honestly, the senior population is far more likely to complete the census online than the person you almost ran over in the parking lot because they were texting. But if this produces another interesting little quirk. A lot of people do not want to put their information online. I get it. There are 10 questions that the Census Bureau is going to ask, and you could probably get half of the information about me with me standing right here today, and whether you know me or not. The 10 questions are not the intrusive types of questions that people think may be asked. Your name, your race, your age, birth date, how many people are living in your household, your race, your ethnicity. Those types of questions are what's going to be on the census. But people are concerned, so we have to be cognizant of that. I'll share with you what I would tell someone that doesn't want to put their information online. You've got 3 other ways you can do it. Number 1, you can fill out a form and mail that in. Number 2, in the past you could call the Census Bureau and say, hey, I need another form, will you please send it to me? You can still do that, but when you call the Census Bureau this time, they will also give you the opportunity to complete the census by phone. That's a new technique. Or if you don't want to do it online, there will be an enumerator that comes to your door if you have refused to to answer the first 5 requests that the Census Bureau has made. So there are 3 ways that you don't have to go online and click submit with your data. The second thing I would say is not everybody's comfortable with somebody coming to the door. A lot of people are not excited about that opportunity. I would say you have 3 other ways that you can do this. You can go online, you can call the Census Bureau and complete it by phone, or you can complete the form. So you've got 3 mechanisms to combat however someone may not want to participate in Census 2020. And we've talked about internet connectivity among this group, throughout the legislature, and across the state over the last couple of years. And we know that not all of the state has broadband access. That could be a challenge for Census 2020. What I will say is I commend the Census Bureau for this. They have made the platform available on desktop, laptop, iPad, Android, and mobile telephone. You can complete the census on any of those devices. So it is entirely possible that communities can go out, develop a strategy where if you have a spring festival and this is going on during the time that the census is being collected, folks can complete the census at the festival. It's all about how you get creative and how you develop the plan to make sure that everybody in your community gets counted. When we're talking about internet connectivity, I want to show you one real-life example, and I didn't know we were going to be talking about this community quite so much today, but Tolliver County. And the last 2 bullet points are what I want you to look at. 85% of the households sent back the questionnaire during Census 2010. I think the past is a great predictor of the future. So 85% of the folks mailed the form in whenever mailing was the option. 60% of the population, this is self-reported data, as of 2017, had no internet or dial-up only. There's the challenge. If you think about election night coverage, whenever the folks go up to the wall and say, we need to look at this precinct to see what's going to go on, here's a great predictor of how this online transformation is going to look in the state. Tolliver County did a fantastic job of participating in 2010. But what's going to happen whenever you get to Census 2020, and folks are going to be encouraged to participate online? So this type of information is what we're going to be looking at and hopefully driving some of the messaging that goes out as we get down the road for census. And one last issue is going to be timing there at the bottom. And what do I mean by timing? I'm going to show you the timeline of when information is going to start coming out. March 12th and 13th of 2020 is when the Census Bureau is going to begin mailing information to households. This mailing is going to go to all of the addresses within their master address database. I'll pat Georgia on the back in just a moment. But if you can read this, there are 5 mailings that the Census Bureau will mail out to each household across the state. I mentioned at the beginning, 80% of the households are going to get the postcard up front saying go online, 20% are going to get the form. If you look to mailing 4, if you have not responded by mailing 4, which begins the second week of April, every household that has not completed the census will get the form. So if you're waiting and you don't want to go online, you will get the form. You don't really have to do anything to get the form in your mailbox. The Census Bureau will be mailing that out. But there will be these 5 points of contact from the Census Bureau to all households. If you want to stop getting the mailings, complete it as soon as you get the first inkling that it's time to go online or complete the form that's been given to you. But there's a little wrinkle in this. There's a small election that could be going on March 24th of 2020. So messaging surrounding the census is going to be challenging. Nothing in the 6 weeks leading up to March 24th, because we've got 2 or 3 candidates running for president. None of the information is going to really get traction, because you're going to have political ads ad nauseum on TV, on radio, on social media, in the newspaper, wherever. You're going to find information about the presidential race, and it's going to drown out any census message. So we're going to have to be strategic about that. I'll hit on that in just a moment. Census 2020 efforts didn't just start now. Every year, cities who have done annexations, or de-annexations for that matter, report their annexations through the Boundary and Annexation Survey. That's what the Census Bureau is using for their foundational element for city limits. And they take the city limit population, they take the county population, do a little math. That's what's in the unincorporated, that's what's in the incorporated. And then the local update of census addresses is the foundational element for that address database that they use. I want to show you one quick thing to pat Georgia on the back, and it will be very quick. If you can tell, this is just a picture because I can't find the slide anywhere. You see Georgia's in the dark blue. Dark blue means more than 85% of the counties have participated in the update of census addresses. There are only 4 other jurisdictions up here. Washington, D.C., which is 1 jurisdiction, state of Delaware, which has 3 counties, Connecticut, which has 8, and Massachusetts with 14. I wasn't a math major, but I think that's 26 political jurisdictions on those 4 states. We have 159, and all 159 were completed either at the county level, the city level, the regional commission level, or through Department of Community Affairs. So our database, I will contend, is going to be the best in the nation. And that means everybody is going to get the information from the Census Bureau. What have we done to prepare? And I'm sorry, these are coming in kind of funny. We did form the State Complete Count Committee a couple of years ago. We're working with the Census Bureau logo and modifying that just slightly. We've got social media presence. We've got presentations that Anna Miller and myself have made around the entire state. We're going from Blue Ridge to Leesburg to Augusta to you name it. We've been all over the state. But one of the most important things that we have done in the last few weeks, is bring on a marketing and PR firm. We developed a strategy that we were looking at, and we knew that we needed help in the execution. Anna and I have day jobs with the state, and we aren't experts in the field of getting the message out, and that's what we are working to do. A number of things that have been put together. We're going to do more. I have to give a quick shout out to a couple of partners through this process. It would have been impossible for us to do without Valdosta State taking the lead on 41 counties in the southern part of Georgia to make sure this message gets out. We couldn't have done it without the University of Georgia. They've produced some materials. They have done field testing, focus groups, so that we make sure that what message we're trying to deliver is going to be well received throughout the state. ACCG and GMA have been huge players in this space as well to make sure that folks across the state are participating in this effort. I know we're short on time. I'm going to try to wrap it up there, but I will throw one more stat at you before I close and pass it off. There are a number of hard-to-count populations within the state. This could be anything from children 0 to 5. It could be those that don't speak English. It could be a whole host of things as classified by the Census Bureau. 99.9+% live within 5 miles of a public library. So if you want a place that people trust in your community that has access to the technology that folks can go online, the public libraries have been an instrumental player. We saw that initially, that it was going to be a player in this, and we reached out to the libraries. They have been tremendous partners. They are going to continue to be tremendous partners in getting the census message out. So with that, I'm going to stop and hand it over to Julie Walker.
Thank you so much. We're thrilled in Georgia's Public Libraries to partner with the Complete Count Georgia Committee and work towards full participation in the census, and I'll talk a little bit about that some more. But I'm very happy to be here today to talk with you all a little bit about public libraries, and I will try not to keep you from lunch too much longer. It's great to see so many of our strong library supporters who've been so good to us over the years in this room, so thanks for having me. I'm Julie Walker. I'm your state librarian, and of course the Georgia Public Library Service, which is my agency, is part of the University System of Georgia. Our mission is empowering libraries to improve the lives of Georgians, and so I'd just like to talk a little bit about how we do that. These are some of the services that my agency provides to libraries throughout the state. We have expert consultants who work with library administrators, trustees, local and state elected officials, and Friends of the Library groups on planning, construction, youth services. You see the whole list here.
It's our philosophy to use our state and federal funding for statewide programs and services to level the playing field, ensuring that every Georgia community has high-quality libraries. Today, we have 407 public libraries in Georgia, at least one in every county. And as Rusty said, almost everybody lives pretty close to one of our public libraries. Libraries are organized in either county or regional library systems. We have 62 systems, 28 are single county systems, and 34 are multi-county regional systems, and those are the two types of systems that are provided for in the state law. We even have a library out on Sapelo Island that you can only get to by boat, so we are truly everywhere. While our libraries serve vital roles in every Georgia town and community, they're particularly important in rural areas. Oftentimes, the public library is central to community gatherings, a hub for educational resources, and a lifeline to the rest of the world. Public libraries across the country offer a variety of paths to help people find new economic opportunity with job and interview support and digital training skills. I'm very proud to say that Georgia was the first state in the nation in which every public library had internet service. And we are still one of only 4 states that can claim that achievement. We've continued our leadership in this critical service area by working diligently to increase broadband speeds while managing rising costs. We've been pleased that more vendors have entered our marketplace, giving libraries more options for higher speeds that they can afford. Our agency works with every library system to identify the service providers and to file applications for the federal E-rate program, which subsidizes internet service for schools and libraries at the rate at which the county qualifies for free and reduced student lunch. Through our offices, we disperse state funds to pay for the remainder of internet costs, ensuring that no county in our state is left out. Georgians use public broadband via public access computers or on their own devices using library Wi-Fi for many purposes that are vital to their success. Students completing homework assignments, adults completing training courses such as commercial driver's licenses even, accessing electronic government services, applying for jobs, many of which now require online applications, or keeping in touch with family via email. We're working with our colleagues at the University System of Georgia to promote the use of library computers to those who are taking the online university courses, since there are more of those every day. While we often take for granted that everyone has a computer and internet at home, we know that's not actually the case, particularly in some of our rural areas. Computer use at libraries continues to climb every year, and use of libraries' wireless networks is growing even faster as patrons come in with their phones or other devices. You can reliably drive by any given public library after closing time at night to find community members in the parking lot still using our Wi-Fi. We're proud of our work in increasing the broadband speeds throughout the state. We leave no stone unturned to find the best value and highest speeds for each of our library systems, and this is our heat map of speeds of broadband that we have in our public libraries. Because libraries are anchor institutions along with schools and hospitals, our libraries have been able to build secure, robust networks in all parts of the state. This really does help with our rural areas. For several years now, the state legislature has generously supported libraries with technology enhancement funds through the bonds. This funding is distributed by our office by a formula to every library system. Those systems may select the technology purchases that support the individual needs of their communities. Items purchased in recent years have included updated public access computers, tablets used in community outreach programming, meeting room equipment, server equipment, 3D printers, and maker spaces. Libraries continue to serve as bridges over the digital divide for their communities. Additionally, this year some funding was specifically allocated in the legislative session for equipment to ensure that libraries will be ready for Georgians to complete those online census forms. So we're working with each of our libraries to make sure they have as many public workstations as possible for that important census work. So I think you can see that we do support people in every phase of their lives. And we also recognize the role that our libraries can play in business and economic development in our state. So for example, our Middle Georgia Regional Library System, which is a 5-county system headquartered in Macon, has a business and nonprofit center that's a one-stop shop for resources and trainings that support the success of local businesses and nonprofits. Individuals who come there can take skill-building classes, learn how to use research databases, receive assistance in identifying and applying for grants, and borrow books on a wide range of business and nonprofit topics. They can also collaborate and network in the space with tables, chairs, and whiteboards. The brand new small business incubator located in the Twin Lakes Library System in Milledgeville is a wonderful example of innovative library service. This incubator helps startup companies in their early stages by giving them space to work at a reduced rate as well as other resources while entrepreneurs work toward the goal of meeting sufficient growth so that they can eventually go out on their own. The Milledgeville Incubator offers office space, access to the library's high-speed internet, workshops and networking events, and other resources aimed at helping businesses start out strong. A growing number of our libraries are offering small business and entrepreneurship workshops that are well attended, and libraries are partnering with their local workforce development units out of their regional commissions as training sites. And these are just a couple more ways that libraries contribute to the economic and workforce development of their communities. Our rural libraries in Georgia rely on our Pines network, and I think a lot of you are familiar with Pines. It was the first of its kind and still the largest in the United States after 20 years. Pines is our borderless library, statewide library card network, allowing over 300 of our libraries to share resources and materials in every corner of the state. Instead of being restricted to the small number of items in any particular library, Pines card holders have access to over 11 million items. They may request an item from any Pines member library, and our statewide courier service will deliver it to their home library free of charge. Library systems across America have emulated our success with Pines, and your Georgia librarians are to be commended for their vision in creating this unparalleled level of resource sharing and cost savings. It is estimated that Pines has saved the state of Georgia over $79 million over the cost that would be incurred if every library system had to purchase and maintain its own automation system. Another of our efforts to ensure equity of access in every county is providing the materials for the important summer reading program, including the reading logs, bookmarks, posters, and all the items that each library needs to run an effective summer reading club. We're committed to providing this important programming to every student, knowing that it's critical to continue reading and learning during the summer so that our kids are ready for school each fall. We're now working with the State Department of Education on a project to put a library card in the hands of every K-12 student in the state.
I'm going to slow you down.
Sure.
We can read the slides.
Uh-huh.
We got them in our book.
Uh-huh.
Are you going to help with the census?
Yes, we absolutely are. As I said, you all allocated about $1 million especially for equipment earmarked to make sure that there are enough public access machines in libraries.
Are your librarians working with the community-based planning groups to get them there?
They are. Anna Miller from the Complete Count Georgia group came and spoke with our librarians at a meeting about a year ago to get them started and point them in the right direction so that they are, and many of my library directors and other staff members are on those committees locally.
Okay. They all should be, right?
They absolutely all should be. And
Okay.
we can do, at every one of we do 3 library directors meetings every year, and we are talking about that every time, making sure that they are heavily engaged in this. It's really important.
I bet you have a performance appraisal. You can make sure that they can do that, right?
Unfortunately, we don't supervise them, but we work really closely with our libraries. Our state library probably has a stronger relationship with each of our public librarians than most states, so we stay in touch with them.
All right. Questions, committee?
Other questions, please?
Chairman Reinders.
Thank you so much, and a couple questions. When it comes to the funding, that is given down to each state
Correct.
and not to the counties, as the county commissioner was concerned about. It's going to get us $2,300.
Right.
Right. And the reason I bring that up is because I look at things through a prism of rural Georgia. And so when we talk about, oh, we were undercounted and robbed, and I get the importance of having an accurate count, I think the unintended consequences of that is that you may miss 10% in Webster County and find 320 people. You miscount by 10% in Clayton on the undercovered population, then those dollars and those legislative seats and a whole lot of other things actually doesn't come to the rural areas that we're sitting there saying that we were cheated. So I just want everybody to be mindful. Is that not correct?
That would be an accurate statement, yes, sir.
So I think, I tell my local officials, be very careful when you're in a small area about talking about how undercounted you were, because the cab in Clayton will eat you up. Secondly, and more, it's true, trust me. Secondly, and more importantly, who draws up the census blocks?
The Census Bureau does that.
Is there a process for changing that?
Yes, sir, there is. It is it's called PSAP, Participant Statistical Area Program, I believe is what the acronym is for, and it allows communities to petition that those boundaries be changed. There are certain parameters with which the Census Bureau evaluates that. It's not something that a community can do just on their own on a whim. There's got to be some rationale behind it, and the Census Bureau has to approve it. But yes, there is, and that should be going on about now.
May I continue?
Yes, sir.
Is there only a certain window?
Yes, sir, there is. It's set by the Census Bureau.
In that window, as I'm assuming, once every 10 years?
It would be, yes, sir.
And the only way that can be done is through the local government. The state has no say-so in that?
I wouldn't say that the state has no say-so in it. The state and local can come together and make a request. It could be a member of Congress in the state and the local make the request. It could come, however, but it does have to originate somewhere other than the Census Bureau if there is something that's wanted in the state.
And I just want Chairwoman Taylor and Chairman Lunston and several others on governmental affairs know the great time we have with some of those annexations and some of those East Cobb situations that's about to come up where census blocks goes into federal land.
Correct.
Becomes problematic.
Correct.
All right, thank you.
Yes, sir.
You bet. Bill.
Thank you. And this may be a question for our emeritus chairman, England. Pay attention. Is Georgia appropriating any money to advertise or try to, I guess, pump up our response rate? Before you answer, because I want to tell you something a little crazy, scary. I was at a legislative conference last week. California is appropriating, not that they have money in the budget, that doesn't matter, but appropriating $240 million because they have such a high, they would consider, well, the homeless population and non-citizen population. They will make sure they're counted. $240 million. So anyway, are we going to appropriate anything? I know it won't be that much.
Rusty and his crew, they do have some dollars that have kind of been built in over the years to kind of keep up with census stuff. And then what we've done with the library system this past year to bolster their system to be able to handle the online census count is some of the things we've been doing. But as far as a major appropriation to say, okay, everybody be sure that you're counted, no, not so much so. But I would tell you that I'm assuming this year is going to be the same as what it has been in the past. The federal government will spend considerable dollars on television, radio, and everything else, urging people to do or to be counted. So I think that's kind of what we're looking
I
for.
wouldn't think it'd be necessary, Bill. It's just crazy when I heard that figure. Yeah, but
Sorry. Rusty, I know you said the Valdosta State was doing 41 counties that they were focusing on, and the University of Georgia, I know through their Archway programs, are working on those counties. I can't do that math in my head, but that still leaves a lot of counties that don't really have a focus group that's working with those counties. Is anybody working on that, or?
Yes, a couple of other things. We have just engaged with Georgia Southern as well. That's been initiated over the last couple of weeks. I expect them to be a partner in this. But there are local complete count committees that have been established all across the state. That could be led by or initiated by the city government, county government, Family Connections, Chamber of Commerce, you name it. But those are existing across the state right now. They're active, they're working, and they will definitely be engaged. And what we are vowing to do is every bit of information that we have available at the state level, we're pushing that out to them. It's no cost. It could be digital, it could be an ad that could be aired, or it could be something you can download and print.
Anybody else? Nobody else? Sorry about that. Thank you. Thank you, guys. Appreciate you. Sorry I cut you off a little bit, Julie. Hey, so that's it. And I sure thank you all for being here and coming to Jasper. If you haven't made your reservations in Moultrie, they better do it, right? Or stay at Sam's house, or in the barn, or something like that. Packing shed. And what we're saying on the notebooks, Sam's got a good view of it right here. Leave the tabs in, Do what? Oh, you're not talking to me. Okay. And then just leave them here, and Holly and Laura, then we'll pick them up. I really appreciate the House Budget Research Office staff being here, and all of y'all. If you need something to let us, we can improve, please give us a call. But that's it. Thank you.